Good morning, ladies and gentlemen, distinguished guests, esteemed medical professionals, all the department officials, seniors, fellow students and juniors. I am Dr. Akshita.
And I'm Dr. Jarshini.
We welcome you to Anaphysis 2023 Divergence.
Today, we embark on an intriguing journey through the complexities of human anatomy as we explore the fascinating world of variations in the upper limb.
In this session, we will uncover the astonishing diversity that exists in the upper limb. We welcome you on board to this enlightening journey of Anaphysis 2023. Nerves are like electric cables. They transmit signals in the form of electric impulses, allowing communication between different parts of the body and the brain.
Now, I call upon Dr. T. Suresh Kumar Sir, Professor of Anatomy, Government Vellore Medical College, to give his insights on variations in the nerves of upper limb firing the wiring.
We welcome the chairpersons for this session, Dr. Jayanti Gnanadeepam Ma'am, Professor and HOD, Department of Anatomy, Tirunelveli Medical College. We welcome Dr. V. Kannan Sir, HOD in charge, Department of Plastic Surgery, Govt Thoothukudi Medical College, to chair this session. We request the chairpersons to introduce the speaker.
Okay. We welcome our Professor Dr. T. Suresh Kumar Sir. He qualified from Stanley Medical College, Chennai, MBBS, then studied DCH in Institute of Child Health, MMC, and he completed his MD Anatomy in Institute of Anatomy, Madras Medical College, and the additional qualifications, he underwent advanced course in Medical Education, CMC Vellore. His experience, he was worked in many PSCs in Government Headquarters Hospital, Valajapet, Vellore. He is working in Government Vellore Medical College since 2011. Post-health, he is coordinator of Medical Education Unit and Research Unit in Government Vellore Medical College, Institutional Review Board and Scientific Committee member, Institutional Review Board, Norway Hospital, branch of VIT. And he is also a library committee member anti-ragging committee member, in charge of cooperative stores, staff advisor for college magazine, NMC assessor for UG and PG courses. He has 11 publications. His professional membership, he is member of Society of Clinical Anatomists, member of Indian Medical Association, member of Indian Academy of Pediatrics. His specialized interest in medical education and microanatomy. He has presented papers in state conference twice, received Best Paper Award in both, delivered many guest lectures, guided many UG in papers, poster presentation in various conferences. Welcome you, sir. You can start your proceedings. Thank you, sir.
Thank you, sir, for the kind introduction. Respected honor of Chief Guest, respected Dean, ma'am, Vice Principal, madam, Medical Superintendent, sir, Deputy Medical Superintendent, sir, Resident Medical Officers, distinguished heads of the departments, professors, faculty members, postgraduates, undergraduates, and those dignitaries who have joined online. A very good morning to you all. And at the outset, I would like to congratulate the chairpersons and the organizers of the CME who have put a great passion into this program. And I also appreciate the work done by the students of this institution. So this is going to be a novel topic as divergence, where we are going to discuss about the variations in the upper limb structures, namely the nerves, arteries, muscles, and the skeletal structure. And the topic I am going to elucidate before you is the nerves. And it has been aptly given a topic called firing the wiring. It is the abnormal or the normal variations in the upper limb nerves. So we'll go to the lecture. So this particular statement we are well versed with. Ontogeny repeats phylogeny. That means the embryonic stages of an animal during the development is going to recapitulate the various stages of the evolutionary history. So this person is a natural biologist called Arthur Mills Walsh, and he has told that this ontogeny repeats phylogeny, but it is basically a book of history where some chapters have been deleted. That is, the structures that we are seeing in lower animals, the animals which are walking on four legs, were not seen in the humankind. And also he says there are some chapters which have not been clearly described in that history. There are certain structures which gets variant as the evolution takes place. So this holds good for the variations that we are going to see. Now, do we really see commonly the variations in nerves of the upper limb? Yes, variations are very common in the arrangement of the formation, the branches of the brachial plexus, especially in the infraclavicular part. And these variations, are they important? Yes, the knowledge of the variations in the nerves are very important for the surgeons, especially hand surgeons, neurologists, and anesthetists. So, as doctors, we need to have a thorough knowledge of the variant anatomy that we will be seeing in the patient. And this person, Friedrich Tiedemann, is basically a physiologist who has clearly stated that doctors without anatomy knowledge are like moles. They just keep on burrowing the soil in the dark, and their hands work for a mound's formation. So whatever we do as doctors without a proper anatomical knowledge is going to be a waste. It is very clear that the basic anatomical knowledge is very important for each doctor who is going to practice, irrespective of the field of medicine. And these are the history, and he is William Osler, who is a co-founder of the Johns Hopkins Hospital. He has quoted that variability is the law of life. So this is the basic thing. variability should be the law of life. And we know about Keith Elmore, clinically oriented anatomy author. He has said that normal means within normal range of variation. So whatever we say it's a normal structure should be within the normal range of variation. We don't have exactly the classical structure in anatomy. So we need to have an open mind and explore. This is the father of modern anatomy, Andreas Vesalius, and he has done a lot of dissections on human cadavers, and he has come out with so many variations illustrated in his book. And this is Eustachi. On his name only we are having the Eustachian tube and Eustachian valve. He has come out with so many colored plates of variants in anatomy even in those days. So it's very clear that there are variants that are happening in normal anatomy, especially in nerves, vessels, muscles, and the bones. So what is the basis of variation? So during embryogenesis, we know that the DNA within the genetic material is going to encode for the body plan. As it encodes, there may be an improvement in the structure of the various organ systems in the body, which will be advantageous, and that will lead on to evolution. That is how the evolution has happened for the advantage of humankind. Suppose if there is a functional abnormality during which the organ fails, then that is going to cause a developmental defect or developmental anomaly, and that is going to cause a death. And if such abnormal variations are going to happen without any functional abnormality, then that is what we call as variant. So the difference between the variant and anomaly is there will be a functional disability in anomaly, and there won't be any functional disturbance in a variant. So it could be an abnormal structure or the structure which we don't see normally, but there will not be any defective functionality. This is the variant. So what are the causes of variation? So there are genetic causes where there will be chemosuppressants and chemostimulants which are going to helpful in the causation of this variation. So especially if you take the nerve, this is the, see here, this is the nerve cell body, and you have the axon, and the axon grows, and the axons, they are grouped into nerve fibers. As the axons grow, we have certain factors. See this in this picture, number 1 is going to be the external signals. So external signals are going to be the extracellular calcium level, neurotropins, then neurotransmitters, etc. And then the second one is intracellular factors, which are going to be like enzymes like kinases and phosphatases, and also intracellular calcium. The third one is going to be the structural reorganization based on the external signals and the intracellular pathways. And these are going to be the modification of the actin cytoskeleton microtubules. So this number 1 is going to stimulate number 2 factor, and this number 2 is going to cause a structural regulation. And then it is going to affect the development of the axon, like it may retract or it may elongate, it may change its direction, or it will go for branching. So this behavior is called the growth cone behavior, and this growth cone behavior is responsible for the development of the axons and the elongation of nerves. And such factors, if they are not usual or normal or not within normal range, variants happen. So this is basically the reason for the variants that are happening in the normal anatomy. So Theodore E. Keats is basically, he's a well-known radioanatomist. He's basically a radiologist who has given so many theories on the variations that he has seen in the radiological images. So what he has told us, the interpretation of normal variants, the interpretation of the normal variants should be incorporated with proper clinical history and physical finding. Otherwise, we will be branding the patients as abnormal. So you have to be very careful. Only when the doctor knows that what is the variant, normal variant, he will be branding each and every patient that he sees as abnormal. So you have to be very careful in diagnosing having the normal variant anatomy in your mind. Now we'll go to the proper topic. So let us revisit the normal anatomy of brachial plexus. We know the brachial plexus has got the nerve roots, then we have the trunks, then we have divisions, cords and branches. The roots and the trunks are going to be in the supraclavicular part, and the roots and the divisions are going to be at the level of the clavicle, and below the clavicle will be having the cords and branches, especially in the axilla. And we know that the C5 and C6, C7, C8 and T1 are the anterior rami which are going to classically form the brachial plexus. So what is going to happen here is the C5 and C6 are going to join to form the upper trunk. The C7 is going to continue as the middle trunk, and C8 and T1 are going to form the lower trunk. Then each trunk is going to divide into anterior and posterior divisions. The anterior divisions of the upper trunk and the middle trunk is going to form the lateral cord, and then the anterior division of the lower trunk is going to form the medial cord, and all the posterior trunks of the posterior divisions of the three trunks are going to cause the formation of the posterior cord, and we know the branches. So we know the formation. If the C4 contribution is large, then that is called the prefixed brachial plexus, and if it is going to be the T2 contribution, that is going to be the postfix. This is also going to be a normal variant. Now we will have the classical nerves that are coming from the brachial plexus. We know the musculocutaneous nerve is a branch from the lateral cord, and it pierces the coracobrachialis. Here also the coracobrachialis has got a deep head and a superficial head in lower animals, which fuses in humans. So this nerve is found to be piercing the coracobrachialis muscle, and it runs between the biceps brachii and the brachialis muscle. It emerges along the lateral border of the biceps and pierces the deep fascia and continues down as the lateral cutaneous nerve of forearm. And the innervation, the motor innervation, is going to be to the lateral aspect of the forearm. Then we have the median nerve, which is also called the labrador's nerve, and the root value we know, it's from C5 to T1. It is formed anterior to the third part of the axillary artery by the union of the medial root and the lateral root from the medial cord and the lateral cord of the brachial plexus respectively. And as it comes down in the cubital fossa, it lies deep to the bicipital upper neurosis along with the brachial artery, and we know this bicipital upper neurosis is also called grace adieu because this is going to safeguard the brachial artery during venipuncture. And it leaves in front of the medial epicondyle, and it leaves between the two heads of pronata teres, and then it descends down the flexor aspect of the forearm between flexor digitorum superficialis and profundus. So it is literally tethered to the undersurface of the flexor digitorum superficialis, and it comes near the wrist, and it enters deep or through the carpal tunnel, and it is lateral to the tendon of flexor digitorum superficialis and deep to the palmaris brevis. So this is the normal course of median nerve that we know in the forearm. And these are the branches that are supplied by the median nerve. And we have the palmar cutaneous branch, which is going to supply the skin over the lateral two-thirds of the palm. And we have articular branches that is going to supply the elbow joint. And we have the anterior interosseous nerve, which is going to supply these muscles, and it is also going to supply the wrist and distal radioulnar joint. So this is going to be the normal or classical description of median nerve. See, this is the palmar cutaneous branch, and this is the muscular or recurrent branch which goes to the tena muscles here. And this is the sensory innervation of the median nerves. You are able to see the green color on the palm. And then we come to the ulnar nerve. The normal course, we know it comes from C8T1, no branches in the axilla. And here we have to the elbow joint, it gives a branch. And then we come down. It is present behind the medial epicondyle. It is present in the groove between the medial epicondyle and the olecranon process. Here the nerve may be compressed, and it can also be palpated, especially in the inflammation of the nerve like Hansen's disease. And radial nerve is going to be the king of the posterior compartments of the arm and the forearm up to the wrist and the hand, dorsum of the hand. And it's going to give branches in the axilla, in the spinal groove, even close to the lateral epicondyle. So these are the muscular branch, articular branch. So generalization in normal. So radial nerve is going to take care of the muscles on the posterior aspect of the arm and the forearm up to the wrist. Then in the arm, we have the musculocutaneous nerve supplying 3 muscles. We know that. And in the forearm, the median nerve on the flexor aspect is going to give 6.5 muscles are going to be supplied by the median nerve and 1.5 muscle by the ulnar nerve. Then in the hand, we have the median nerve is going to supply 5 muscles and the ulnar nerve is going to supply the 15 muscles. Totally, we have 20 muscles in the hand. Okay. And the movements in the shoulder joint is going to be taken care of by the C5 segment. Then the flexion of the elbow by the C6 segment. And the extension is going to be by C7. And the movements at the wrist is going to be by the C8 and T1. This is the generalized classical theory that we study. Okay. And this is the sensory supply. So we know here the C3, C4 by the supraclavicular nerves is going to supply the shoulder and the root of the neck. Then we have the C5, C6 near the forearm and the wrist and the thumb. Then we have the C7 in the middle. Then we have C8 and T1. So this is going to be the normal motor and sensory innervation. Now we are moving into the variations. So what is the generalization is any errors or variations in the arrangement of nerves that happens proximally is going to be corrected distally. So if there is any variation near the axilla in any of the nerves of the brachial plexus, that is going to be corrected as it goes near the target organs like the muscles. So this is going to be a statement that we need to remember. Okay, so any variant is going to be automatically corrected distally. So do you have Slido? Students have Slido? Any of you? So can we just answer this question? Variations are commonly seen in which answer? Median nerve. Okay, so median nerve. Even axillary nerve it comes. It's the median nerve. So more variations, normal variations happens in the median nerve. So as you dissect, please anticipate variations in the median nerve. So the median nerve is the nerve that is very commonly involved in the normal variation. Okay, thank you. And now we'll go to the variations that are affecting the brachial plexus and its parts. So we need to group them into the variations that affect the roots, the trunks, the divisions, the cords and branches. As we revisited the brachial plexus, now we are moving on to the variations that we are going to see very commonly. So I am going to present the variations that are very commonly described in the standard textbooks. So as I embarked in this journey of preparing for this topic, I was seeing so many variations that have been presented in systematic review. But the standard textbooks, whatever I have come across, I have taken with references and I am going to present so that it will stimulate and instigate your mind so that if you happen to see any dissection in the upper limb, and you will also apply other regions also, you will anticipate all these variations. Okay, we'll go inside one by one. See, basically, the 7th intersegmental artery is the reason for the development of subclavian artery. The subclavian and axillary stem artery is going to come from the 7th intersegmental artery. But if 6th or 8th or 9th are involved, there will be definitely variations in the formation of brachial plexus. Even in the formation of trunks, divisions and cords. So the basic idea is, if there is a formation of axillary artery and the subclavian artery defect, then there will be variations in the brachial plexus formation and its branches. So we expect such variations only in these patients. This is what I called as prefixed and postfixed. Here we have the C4 contribution, which is large, and the T1 is almost nil. So this is prefixed, and this is postfixed. Here we have T2 involvement, and there is a little bit of C5 involvement. So we know this prefixation and postfixation. So the theory behind is, they say what is actually prefixed and postfixed we call is nothing but the elongation of the segmental level of brachial plexus formation in the spinal cord. So the amount of nerves that are contributed by the anterior horn cells in the cervical spinal cord, it differs. So there may be elongation. So that is what is actually we see it as prefixation and postfixation. Okay? Yeah. Now, the roots of the brachial plexus, we have this accessory phrenic nerve. The accessory phrenic nerve is formed by the contribution of ansa cervicalis, that is C2, and also the nerve to subclavius, which is going to be C3. You know what is ansa cervicalis? Yes, it is. Where is that present? It is in the triangle. Which triangle? Carotid triangle over the carotid sheath. Okay, so that is going to contribute in the formation of this particular nerve called accessory phrenic nerve. And sometimes the nerve to subclavius, you know where is the subclavius muscle, right? So that subclavian nerve is also going to contribute. If that accessory phrenic nerve is present, it is going to be in communication with the actual phrenic nerve, the classical phrenic nerve around the subclavian vein. So this is going to be a variant. You have to be very careful, and you have to anticipate this kind of variation, especially in 1/3 of the general population. It is so common. And then we come to this long thoracic nerve of Bell. It is going to supply the serratus anterior, right? So it is going to have a very long course in the neck as well as on the thoracic cage. And that is also going to be involved in this scalene musculature. When it is going to compress the nerve, that is going to get compressed, and that is going to cause abnormality. So there may be a long course of this long thoracic nerve of Bell, which is especially vulnerable for compression using scalene musculature. And then there will be absence of upper trunk. Upper trunk is formed by C5 and C6. Or that may be absent. Posterior cord may be absent. The contribution to the medial nerve formation, that is the medial root of the medial nerve formation, is going to come from the medial cord. That contribution may be defective. That will come from the middle trunk, or ulnar nerve formation itself will come from the middle trunk. So these are the variations that are going to happen in the trunk of the brachial plexus. Then we have the suprascapular nerve. The suprascapular nerve is going to pass through the suprascapular foramen. You have a suprascapular notch, which is bridged by the ligament to form the suprascapular foramen, and through this, the suprascapular nerve passes through. So that may come from the upper trunk proper, that is the classical teaching, or it may come from the posterior division of the upper trunk. It is not from the upper trunk, rather the posterior division of the upper trunk can give rise to this suprascapular nerve. In that case, the patient will be having a symptom which will resemble periarthritis of the shoulder. You know what is periarthritis of the shoulder? Instead of pain over the scapular region, they will be having pain around the shoulder joint. So this will be mimicking the periarthritis shoulder. So you have to be remembering this suprascapular nerve, which may be entrapped in the foramina here. So this is called suprascapular nerve entrapment. Then here we have the trunks usually formed in the lower part of the posterior triangle or at the level of the clavicle. Sometimes it will be very low. It will come down onto the axilla. So the division of the lower trunk and the formation of definitive medial and posterior cords may happen in the axilla instead of the neck. So it will be lower down. Okay, so that is also possible. And see here, C5, C6, it has to form the upper trunk. C7 is to continue as the middle trunk. But here, C5, 6, 7, together it is forming the lateral cord. This is also classically described in many texts. So instead of forming an upper trunk and a middle trunk, all together they form the lateral cord. It's going to be a common lateral cord from where we have the lateral cord proper that comes out. And that is also going to contribute a large branch to formation of the posterior cord. How is posterior cord formed? The posterior cord is going to be formed by the union of all the posterior divisions. So instead, so there is a contribution from this lateral cord in the formation of posterior cord here. So this is also common. They say around 3 to 4% of general population, they have this kind of a variation. And here, this scientist, Canadian scientist, he has told that all these variations in the trunks and the cords are because of the wrapping around of this sheath, facial sheath. If you are very carefully dissecting the facial sheath, then you will come across the normal anatomy of brachial plexus. So all this trunks and divisions formation will be normal if you very closely and carefully dissect the facial sheath around the trunks, divisions and the cords. So he comes with this. And there's one more scientist called Singer. He told that there is a possibility of single common cord. Instead of having 3 cords, having single common cord because of the defective formation of axillary artery. So you have to remember, if there is a defect in the formation of axillary artery, and if there is a lot of facial sheath surrounding the roots, trunks and divisions, then there could be a normal variation of the brachial plexus. But during surgery, you have to anticipate these variations and you have to be very careful in dissecting. Then we come to the cords. So we know that there are 3 cords. They are posterior, medial and lateral cords. The lateral cord is going to lie laterally, and the posterior cord is going to lie posteriorly, and the medial cord is going to lie medially in relation to the second part of axillary artery. But when some of the observations have shown all these cords, they lie lateral to the axillary artery. So if they want to give axillary block, they have to recognize this variation and they have to insert the needle lateral to the axillary artery. Okay, if we don't have this anticipation, we will be definitely entering into the axillary artery instead of the block into the axillary nerve. So the 3 cords lying laterally alone to the axillary artery is also possible. And see, these or other variations that are very commonly seen by many of the investigators. The lateral pectoral nerve, we know it comes from the lateral cord, but instead it comes from the anterior division of the superior trunk or the middle trunk. And the medial pectoral nerve is to come from medial cord, but it is coming from the anterior division of the middle trunk. See, the suprascapular, it has to come from the superior trunk. Instead, it will take only C5 fibers, or from the posterior division of the superior trunk. The nerve to latissimus dorsi, it has to come from the posterior cord, but it can emerge from axillary nerve or radial nerve. See how different are these presentations. The upper subscapular and the lower subscapular posterior cord, they also come from axillary nerve. And then the medial cutaneous nerve of arm should come from medial cord, but they can come from the inferior trunk itself. We don't have a medial cord giving rise to this cutaneous nerve. Instead, it comes from inferior trunk itself. Similarly, the medial cutaneous nerve of forearm, instead of coming from the medial cord, it emerges from the inferior trunk. Okay. And these are the various segments. See, especially when you see this suprascapular nerve, so it has to come from C5 or C5-6 segments. But the nerves may come from C4, C5, so we will be having pain high above the shoulders. Similarly, the long thoracic nerve, the usual root value is C5, 6, 7, but it may take only C5 and C6 or C6 and C7. So even at the level of the emergence of the roots, in the formation of these nerves, there are variations. So we need to have a high index of suspicion, even normally, for these kind of variants. In the lateral cord, see here, this median nerve, normally it comes from C5 to T1, but it can stop from C5 to C8, or it can C6 to T1. All these possibilities are there in the normal variants. And here the medial cord, again, ulnar nerve. See the ulnar nerve? It is C7 and T1, but it can come from C5 T1, C6 to T1. So there are so much of variations in the segmental innervation through this nerve. So you cannot just fix that ulnar nerve should have only these roots, but nerves can emerge from the other segments also. So many possibilities of variants are happening in the upper limb nerves. So you have to have, again, I just reiterate that you have to have a high index of suspicion, especially the people who are involved in hand surgery and the nerve grafting and the tendon grafting. And this is the posterior cord. You have the axillary nerve. See the axillary nerve. It usually comes from C5 and C6, but it can involve the C7 also, and it may come only from C5. So these are also the segmental variations of the common nerves that we see in the upper limb. So what is this movement? Flexion where? This. Do you know what segment, spinal segment is involved in this? Let's try. Slido. Started? Yes. Posted? Anyone posted? Yes? Shall we move on? Oh, good, very good. So, what is it? CAT1. Okay, CAT1. So, all these things, it should just come as such for you. Okay, you cannot forget. All right. So, CAT1 is the correct answer. Good. Next slide. Right. This is a photograph where, so here we have the median nerve. So, this is the median nerve. And this is the medial root of the median nerve. This is the lateral root of the median nerve. And here we have the ulnar nerve. Okay, this is the ulnar nerve. And see, there is a communication branch between the lateral cord and the medial root of the median nerve. See here, you're able to see the CB communicating branch. And this is also possible. So this is a communicating branch between the median nerve and the lateral cord. See here. Next slide. And see here, this is the number 1. See here, number 2 is going to be the medial root. Number 1 is going to be the lateral root. And this, the 3 is the median nerve. And here 4 is the musculocutaneous nerve. And there is a communication branch between the musculocutaneous nerve and the median nerve. See here again, we have the 1 and 2, the roots of the median nerve. 3 is the median nerve, and here from the lateral cord itself there is a communicating branch, that is 5. Okay, so I just want to stimulate your anticipation when you are dissecting the brachial plexus, that these are the variations that are very commonly seen. Next slide. Next slide.
Yeah, see here, this is between the ulnar nerve. So ulnar nerve is here and the median nerve is here. So there is a communication between the ulnar nerve and the median nerve. See here. So median nerve and ulnar nerve. All right. Next slide. Next slide, please. Okay, here. It is between the, so here we have the radial nerve and there we have the ulnar nerve, and this is the communication between the radial nerve and the ulnar nerve. Okay. Next slide. And see again, it is between the ulnar nerve and the medial cutaneous nerve of forearm. See here we have the medial cutaneous forearm and this is the ulnar nerve. So both are coming from which cord? Medial cutaneous of forearm and ulnar nerve? Medial cord. Okay. So you will be having axillary artery and vein. In between you will be having these two nerves. You remember the brachial plexus dissection? Yes. Okay. This is going to be the high division or bifid median nerve, which is very commonly seen near the wrist joint before the carpal tunnel, and you have to be very careful, mindful when you are decompressing the carpal tunnel in carpal tunnel syndrome. And this is one variation that we have seen last year in Vellore Medical College. See here what happens is, see in this place, the median nerve is coming here, and from the ulnar artery, there is one artery which is the persistent median artery, which is coming down in between the divisions of this median nerve. So it comes down laterally to the median nerve, then in the middle of the forearm, and near the wrist, again, the median nerve divides into two. See the persistent median artery, it comes in between the two divisions of the median nerve. So there is a high division of median nerve even before the carpal tunnel, and this median artery, it comes in between the two branches of the median nerve. This median artery is coming again, peeping in between the two branches of median nerve. See again, see you are able to see the persistent median artery coming from the ulnar artery. It is piercing the median nerve and then it comes up from the posterior aspect. Then it so again near the wrist, you are able to see the median nerve being divided into two, and the median artery comes in between. You are able to appreciate? So the nerve divides and the artery comes in between. Okay. So this is also possible, and this you have to take care when you are operating on the carpal tunnel. See here, if this persistent median artery is present, it will be within this epineurium with the two divisions of median nerve. It may be on the medial side, on the lateral side, or in the middle, and it may be outside the epineurium also. So these anatomy are possible if you have a persistent median artery and a division of median nerve. Okay. And these are the various anastomosis that happens between the motor nerves, motor component of ulnar nerve and the median nerve. And this is called Martin-Gruber anastomosis, and it is the forearm, and when it happens in the hand, it is called Richer-Caneux anastomosis, RCA. So these anastomosis are also possible, so you have to keep this in mind. And if it is going to happen in the palm, it is going to called Bertini association, and it is anastomosis, and this is going to be between the sensory component of the ulnar and median nerves. So we have these three anastomosis. So what are the clinical importance of these variants? One is the variation can be because of the nerve course or the structure. The other one may be because of the surrounding structures that will compress or entrap the nerves. Just like, see you have the muscles, accessory muscles may be there, ligaments may be there, osseous foramina will be there. They can entrap, just like a cubital tunnel syndrome, carpal tunnel syndrome. So we also have this supinata syndrome and pronata syndrome. All these can happen when there is abnormal structures surrounding the nerves. And similarly, the nerve stimulation test is considered to be a blind technique if at all you don't know the basic variance that can happen in this region. For the anesthetist, a clear knowledge of the normal variance is very important in order to give the blocks, regional blocks, and also to avoid injecting into the blood vessel. So ultrasound is very useful in guiding the anesthetist to give a block accurately. So anatomical variation of the brachial plexus is very common. It is not something which is very rare. It is common, and every doctor, especially the hand surgeons, anesthetist, and also the orthopedics should be having a very good and thorough knowledge of the normal variance, and it is very useful in the conduct and outcome of regional anesthesia. So the brachial plexus variant can happen all the way from the roots up to the branches. So it could be because of the defective formation of subclavian and axillary artery, or it may be because of oversheathing of the facial sheaths around the cords and the branches and the trunks of the brachial plexus, or it could be because of the surrounding structures which will cause some new features because of the compression and entrapment. So that we should always remember. You know what is the nerve involved here? Is it axillary? Radial nerve. So what is it? Stretch palsy. Very good. So which variation is striking for you? Among all these variations that we have seen so far, which variation do you think is very interesting or very striking for you? Median nerve. That's all? So median nerve has got the highest propensity to have variation. So that is the carry-home message. So when you are getting involved with the dissection of brachial plexus, or when you are in surgery and orthopedics and anesthesia, please remember median nerve is one of the nerves that is very common. Good. So many median nerves. Very good. So median nerves are going to be affected very commonly with normal variations, and especially when you are doing hand surgery or carpal tunnel decompression, you have to remember this. Okay, clear? So did I give you a glimpse so that it will be interesting for your career? Yes, thank you. So these are my things. So I thank the organizers again for giving me an opportunity for coming all the way here to present this particular topic. I especially thank your Professor Dr. Dhanalakshmi Madam and the administrators, and I also thank the chairperson for giving me a nice introduction. And I also remember my faculty way back in Vellore who have really helped me to just go through all the systematic reviews. The last 1 week or 10 days we have been only talking about variants in the department, and thank you all the best. Thank you so much.
Thank you, sir, for your profound insights. I request the chairperson to share few words.
Thank you, sir, for giving this excellent and more wide knowledge about the variations of nerves in upper limb. I think this is very useful for the PG students and anatomy faculties for the research work. And it is also very useful for the surgeons in nerve entrapment surgery and reconstructive surgery, and also in pain management therapy. In our routine dissection, anatomy dissection, we have seen many variations in the median nerve in its formation and course. But and also in musculocutaneous nerve, we have seen many variations, but we cannot usually concentrate in the variations in the minute branches, small branches, and in the carpal tunnel. Okay, it's very useful, sir. Thank you so much.
Very excellent Excellent lecture, sir. In our first year MBBS during 1993, Dr. Hariharan sir used to dissect brachial plexus anatomy for us. Totally we had 6 cadavers. In brachial plexus, the variations, we will be very much interested to see that variations in any of the cadavers, and it will be explained much more detailed than the routine anatomy. And also during our clinical practice, whenever we see hand injuries, even with either a lateral most finger or in the medial most finger, we want to suture, we will give block to all the 3 nerves. So because of this variation during procedure, we will be feeling difficult whether we have given the block adequately or not, whether any variations is present or not. So to avoid this, during the procedure of suturing, to avoid such a confusions, we used to give block to all the 3 nerves and proceed with the suturing, so that it will be easier and pain free for the patient. So we have to keep it in mind while suturing the hand cases. We have to give block to all the 3 nerves in the wrist block. So thank you so much, sir.
Thank you, sir. Thank you for adding the notes, sir. Thank you.
I kindly request the chairpersons, Dr. Jayanti Nanadipam ma'am and Dr. Kannan sir, to felicitate Dr. Suresh Kumar sir. We have now come to a special moment in our program. It is with great honor that we would like to invite the head of our anatomy department, Dr. Dhanalakshmi ma'am, to come forward and join us on stage to present this memento to Dr. Jayanti Nanadipam ma'am. I request Dr. Dhanalakshmi ma'am to present the memento to Dr. Kannan sir.
We welcome all the HODs, faculties and postgraduates to Anaphysis 2023. Moving on to our next session, may I now request Dr. K.R. Arun Kumar sir, Professor of Anatomy, Dhanalakshmi Srinivasan Medical College, Perambalur, to the podium to deliver a session on the variations in the muscles of upper limb, muscular maze.
I have the great honor and privilege to invite and introduce the chairpersons of this session, Dr. K. Arumugam sir, Dr. Rakesh Fernaldo sir, Dr. Bharati Rani ma'am. Dr. K. Arumugam sir is currently the Associate Professor in Anatomy in Thoothukudi Medical College. Dr. Rakesh Fernaldo sir is the Professor and HOD, Department of General Surgery in Government Thoothukudi Medical College. Dr. Bharati Rani ma'am, Associate Professor of Government Sivagangai Medical College. I request the chairpersons to introduce the speakers. Over to the chairpersons.
I'm happy to introduce Dr. K. Arun Kumar. He is a professor and HOD of Dhanalakshmi Srinivasan Medical College, Perambalur. He is done in undergraduate at He done his undergraduate at BMKV Medical College at Salem and completed his postgraduate at MMC Chennai. He had an advanced course in medical education in CMC Mellur. He is an assistant professor at Dharmaburi Government Medical College for 8 months, and now he is working at the Dhanalakshmi Srinivasan Medical College. He is a whole various posts. He is a coordinator of medical education units. He is a NAC coordinator. He is an ethical committee member, a research committee member, and the NAC core committee member, editor in Trends in Medical Science, reviewer in Anatomy in Tamil Nadu, Dr. MGR Medical University e-Journal, reviewer in Applied Clinical Informatics. He had published 13 journals in various national and international journals. He is a member of IMA Life Member. He is a Life Member of Society of Clinical Anatomists. His specialization in the medical education and osteologies. He has presented papers in state conference and speaker in CME and workshop. He has organized national workshop in plastination on museum technique in 2021. He has organized 4 CME. He organized state level anatomy art competition in 2022. He guided many UG, PG students in paper and poster presentation in various conferences. Welcome you, sir.
Thank you, sir. Thank you, sir. Thank you for my introduction. Very good morning to all. We go for the second session, that is the muscular maze. What are the variations present in the upper limb? Okay. What are the muscles variation present in the upper limb? Okay. I am very much privileged to stand in front of you to present this topic because this is a wonderful topic. I thank the organizers for choosing this topic because this kindles the interest in research field. Okay. So already as Sir has mentioned that William Osler quoting, variability is the law of life, and even our legendary lyricist, that is poet Kannadasan, he has also mentioned this regarding the variability, that is Matram என்பது மானிட தத்துவம் மாறும் உலகின் மகத்துவம் அறிவேன். Okay. So this is the variability of life, and he understands or he appreciates what is the significance of the variations. So coming for the muscles of the upper limb variations. So why do we want to know the variations of the muscles in the upper limb? Okay. The first one is the skeletal muscles. We all know that they are the motors of movements at the joint, and they produce the movements of the joint. So they're called as motors of movements. And if there is any anomalous head of a muscle or any accessory muscle, the first thing is it will restrict the movement of the joint. So it is altering or it interfere with the biomechanics of the joint. And second thing is the additional aid, if it is overused or sometimes can go for injury, so that will result in a tear, and that may confuse a surgeon during operations. And the third thing, for a radiologist or any pathologist, it may confuse with the pathologic conditions like tumors. And finally, the most important one is the compression syndromes. It can compress the neighboring structures like arteries and nerves, and that is the reason for the appearance of the clinical features in the variations of the muscles. So they cause entrapment syndromes, they can cause pressure neuritis, or they can compress the neighboring blood vessels. So what are the reasons for the occurrence of variations in the muscles in the upper limb? Okay. We all know that the somites, which are developed from the paraxial mesoderm, they give rise to the skeletal muscles in our body. So these somites, mesodermal somites, they will migrate to the upper limb bud during the 5th week of intrauterine life. So after entering the upper limb bud, these somites, they will arrange along the preaxial border and then postaxial border of the upper limb. And then second stage, in the later stage, they will regroup as the ventral group muscles and then dorsal group muscles. So ventral group muscles, they will remain as the flexor muscles, and the dorsal group muscles, they will remain as the extensors. So during this regrouping, there may be reduplication or abnormal splitting of the somites. So this abnormal splitting or reduplication can result in the abnormality in the skeletal muscles of the upper limb. Either there may be accessory muscle or there may be accessory head of a muscle. So that is the reason for presence of variations. And these reduplication and abnormal splitting, why does this occurring is because of sometimes there may be genetical inheritance from the parents, or from the persistence of embryonic condition from the parents also. We'll go for the muscles. So what are the muscles? There are plenty of muscles which have variation in the upper limb, and we are going to see just on a glimpse of that, which are clinically important. The first is we go for the pectoral region. So what are the 3 muscles present in the pectoral region? UG students? Yes. Usually we start with this dissection with the pectoral region, isn't it? Okay. So what muscle you encounter first? pectoralis major. Okay, so then comes the pectoralis minor, and then comes subclavius. So coming for pectoralis major, this is very, very important muscle during reconstruction procedures in the plastic surgery. Okay. So the most common variation occurring in the pectoralis major is the absence of the sternocostal head. Okay, that is the reason, that is the most common variation occurring in the pectoralis major, the absence of the sternocostal head. So when this head is absent, the compensatory mechanism is there will be hypertrophy of the clavicular head. So that will maintains the movement of the shoulder joint. So complete absence of pectoralis major muscle is always seen with the Poland syndrome. And what are the consequences of this defect in the pectoralis major muscle? There will be sometimes no functional deficit, or there may be little deficit due to the compensatory action of the surrounding muscles. The only main thing is there will be decreased power of horizontal adduction, and there will be decreased peak torque of the horizontal adduction of the shoulder joint because of the defect of the pectoralis major muscle. And in this image, you can see some of the variations of the pectoralis major muscle. In the first image, you can see that is the normal anatomy here. You can see cephalic vein here. This is the clavicular head, sternocostal head. And here you can see there is a cleavage between the clavicular head and then sternocostal head. And the deltopectoral groove is seen obviously because of the hypertrophy of the clavicular head. Here, the cephalic vein is exposed here. You can see here. In this third image, once again, there is hypertrophy of clavicular head, where you can see the exposed of cephalic vein. And here, both the clavicular head and sternocostal head remain merged, and that is hiding the cephalic vein. So any variation in pectoralis major may alter the course of the cephalic vein. That is a point to be noted. And as I already told you, the pectoralis major muscle forms an important part during reconstruction procedures in plastic surgery, especially in the breast implant surgeries. The integrity of the pectoralis major muscle improves the aesthetic appearance, and then improves the aesthetic appearance after the reconstructive process of the breast surgeries. And they also decrease the risk of capsular contracture. The very good vascular pattern of the pectoralis major is present, and that will maintain prevent the capsular contracture. So that's why pectoralis major muscle is very important, and we must know the variations of the pectoralis major muscle. Coming for next muscle, that is the pectoralis minor muscle. We all know that is inserted to the, what is the insertion of pectoralis minor muscle? To the coracoid process of scapula. Okay, that is inserted to the coracoid process of scapula, whereas sometimes it may be inserted to the capsule of the shoulder joint. Okay, so that will persist as the coracohumeral ligament. So Grant's textbook says that coracohumeral ligament is the detached part of insertion of pectoralis minor, and this paper, that is case report reported by Tubes in 2005, he reported that this anomalous insertion of pectoralis minor to the capsule of shoulder joint, and that is going as the coracohumeral ligament. So this case report has justified the Grant's suggestion that coracohumeral ligament is the detached part of the remnant of the pectoralis minor insertion. And we spoke of Poland syndrome in the first slide when we talk about the pectoralis major. And what are the clinical features of Poland syndrome is, there will be hypoplasia of chest wall muscles, and along with that, you can see there will be hypoplasia of the pectoral muscles, especially pectoralis major, minor, and sometimes there will be upper limb muscles also, there will be hypoplasia. And it also include, the Poland syndrome will also include webbing of fingers, that is called the syndactyly, and also includes the symbrydactyly. There will be a short fingers and clubbing of fingers, and there will be ectrodactyly, where you can see absence of some of the fingers, and there will be a split in the hand, that is called as ectrodactyly. So all these are the clinical features of Poland syndrome. And why does this Poland syndrome occur? The reason is, during embryogenesis, during development, there is disruption of the arterial blood supply from the subclavian vessels to the upper limb bud. So that will result in the Poland syndrome. And sometimes there will be disruption in the development of lateral plate mesodome. So that also results in the Poland syndrome. The next and anomalous muscle, we all know that is the pectoralis minimus. Okay, so origin, it takes origin from either from the first rib or from the second rib, and is inserted to the coracoid process, that is the attachment of this anomalous muscle, that is pectoralis minimus. So it takes origin from the first rib or second rib and is inserted to the coracoid process. The nerve supply is usually supplied by the lateral pectoral nerve. And what is the clinical importance of this presence of this muscle is, this muscle, it is a neighbor to the, or is nearby to the thoracoacromial vessel, which is the branch coming from the axillary artery. So the thoracoacromial vessels may pass either superficial or deep to the muscle, and that will result in the compression by the muscle. And you can see this image here. This is the normal pectoralis major muscle, and you can see a small belly coming from first rib and is inserted to the coracoid process. So this is a pectoralis minor muscle, and in this image also can appreciate the presence of a variant muscle here. So this is the pectoralis minimus muscle, whereas you can see the normal anatomy here. This is the minor, and the major has been retracted here or reflected here. Okay. So this you can see anomalous muscle, that is the pectoralis minimus muscle. And there is another muscle in the pectoral region, an anomalous muscle, that is called as pectoralis tertius. You can see here this muscle, a small belly coming from xiphoid process. So it takes origin from xiphoid process and is once again it is inserted to coracoid process, and this may be either supplied by either medial pectoral nerve or lateral pectoral nerve. That is the pectoralis tertius muscle. Then once again another muscle that is called as chondroepitrochlearis. The name itself says the attachment of this muscle. So chondro means, what is the meaning of chondro? Cartilage. Okay. So it takes origin from the cartilage, costal cartilage, that is from the lower ribs of the costal cartilage. And what is trochlea? Where is which bone contains the trochlea? Humerus. Okay. So epitrochlea means epicondyle. So this muscle chondroepitrochlearis, it takes origin either from the aponeurosis of external oblique muscle or from the costal cartilage of the lower ribs, or it may arise from the infralateral aspect of pectoralis major muscle. Okay, that is the origin. And insertion, it is inserted to the medial epicondyle of humerus, or may be inserted to the medial intermuscular septum of the arm. That is the attachment of this muscle. And nerve supply, it is supplied by medial pectoral nerve. So you can see a muscle here. This is the chondroepitrochlearis, which is arising from the infralateral aspect of the pectoralis major muscle and is inserted to the intermuscular septum here. And you can see another muscle here. So anatomists will be knowing this. So this is called as axillary arch muscle. Okay, we'll see that. So you can see two anomalous muscle here. They have a common insertion here. They are inserted to the intermuscular septum here. Then what are the disadvantages of presence of all these muscles, especially this chondroepitrochlearis? The previous slide we saw that this muscle, it is crossing the axilla. Okay. So what are the contents of axilla? Axillary artery, and most importantly, what nerve plexus we have? Brachial plexus. Okay. Since this anomalous muscle is crossing the axilla, it may compress the brachial plexus or the neighboring artery. So it will result in the nerve impingement, or it can complicate the procedures in the axilla, especially when you remove the lymph nodes from the axilla. So during that time also, it can complicate the surgical procedure because of presence of this anomalous muscle. And it may also cause functional impairment by limiting the full abduction of shoulder joint because of connection between this connecting the chest wall and the humerus. This may restrict the full abduction of shoulder joint. So these are the complications of presence of this muscle, that is chondroepitrochlearis. Moving to the next region, that is back muscle. So we have most commonly trapezius, latissimus dorsi, and then we have the levator scapulae, rhomboides major minor. Okay, we'll omit all those muscles. They are only of academic interest, and we'll confine to muscles which have clinical importance. So coming for back muscles, we have trapezius. So trapezius sometimes may be completely absent, and sometimes they may be partially absent. Even Gray's textbook says that sometimes the occipital attachment may be missing from the trapezius, and the clavicular attachment may extend up to the middle of the clavicle. What is the normal insertion of trapezius to the clavicle? To the lateral 1/3. Okay, so Instead of being confined to little 1/3, it can confine to the entire length of clavicle and may blend with the sternocleidomastoid muscle. So in those time, there will be a defect between these two muscles, and through the defect only, the external jugular vein passes. And the next additional muscle in the back, that is in the neck region, is there is a muscle called as, the muscle has been reported, that is called as cleidocervicalis. So what does it mean by cleido? Related to which bone? Clavicle, okay. So it's got attachment to clavicle and takes origin from the cervical vertebra. So it takes origin from the cervical transverse process of second and third cervical vertebra and is inserted to the lateral aspect of the clavicle. That is the attachment of this muscle. You can see a abnormal muscle here. So this muscle is called as cleidocervicalis. So it may be present in 2% of population, and it always lies deep to the cervical part, that is upper part of trapezius. So that muscle is called as cleidocervicalis. And we all know this common muscle during our PG times or during UG times, that is the axillary arch muscle, also called as Ashelbogen muscle or Langer's muscle. And this muscle, it is abnormally crossing the axilla. So it takes origin from the latissimus dorsi and is inserted to the lower aspect of the pectoralis major muscle. It crosses the axilla. So this muscle is called as axillary arch muscle. So this muscle, it crosses the axilla anterior to the axillary vessels and brachial plexus. So there is a chance for compressing these two structures. So you can see in this image. So you can see latissimus dorsi, and this is the pectoralis major, and you can see the muscle here. So this is the axillary arch muscle. And what are those structures? What is the structure? Can you able to identify that? What artery is that? Axillary artery. That is the axillary artery. You can see the branches of cords of cords of brachial plexus, and you can see branch of brachial plexus. So you can see anomalous muscle here. That is the axillary arch muscle. And this muscle can be clinically palpable in the axilla, and it causes the neurovascular compression in the axilla. The next anomalous muscle, once again crossing the axilla, is called as dorsoepitrochlearis. So origin, it takes origin from the latissimus dorsi tendon. You can see a muscle here. So this muscle, you can see a small bulge here, muscle bulge in the axilla. So this is nothing but the dorsotrochlearis, epitrochlearis. So it arises from the latissimus dorsi tendon and is inserted to the lateral epicondyle of humerus, or maybe inserted to the olecranon process of ulna. Sometimes may be inserted to the long head of triceps. It is present in the 5% of population. A nerve supply, it is supplied by the same nerve for the latissimus dorsi, that is thoracodorsal nerve. So what are the complications of presence of this axillary muscle in the axillary region is mainly impingement. Okay, they will compress the neighboring structures like axillary vessels and then brachial plexus, and also they restrict the movements of the shoulder joint, especially the subduction. So coming for next region, that is scapulohumeral muscles, muscles attached to the scapula, to the humerus, supraspinatus, infraspinatus, subscapularis, like that. So among this muscle, we have taken only the deltoid. So deltoid is very important during reconstruction procedures while taking a flap for any correcting any defect. So this is the importance of deltoid. So variation can occur in each part of deltoid. Variation can there be absence of any of the parts of the deltoid. Their clavicular part may be absent. The acromial part may be absent. The lower part may be also absent. Okay. So all this absence can be noted in the deltoid, and deltoid may be inserted into the long head of biceps to create a structure like a single muscular ribbon going from the acromion process to the radius. That is also reported, and sometimes it may be inserted to the lateral intramuscular septum. You can see the deltoid muscle, it is going as a common belly along with the biceps brachii towards the this radial tuberosity of the radius. Okay. You can see accessory deltoid here, this fibers, this is the main deltoid, normal deltoid. You can see an abnormal head, which is present lower to the normal deltoid. So this is called as accessory deltoid. And implications of this deltoid variation is deltoid is very essential for raising flap during surgeries, reconstruction procedure, especially during correction of tetraplegia by transfer of triceps, and by correcting the radionecrotic defects over the shoulder joint, or reconstruction of upper limb, or any repairing the rotator cuff tears. So in all those times, we have to raise the flap from the deltoid. So we must know the normal the variations which are occurring in the deltoid muscle. We'll go for the muscles, variations of the muscles in the arm. So coracobrachialis, so what is the nerve which is passing through the coracobrachialis, which is traversing the coracobrachialis? Musculocutaneous nerve, okay. But many times, the musculocutaneous nerve may not traverse the coracobrachialis. And some fibers of coracobrachialis may be inserted to the shoulder joint. So that fibers are named as coracobrachialis superior or coracobrachialis brevis. And sometimes coracobrachialis may be inserted to the medial epicondyle, and it may persist as ligament of Stuthus. Okay, have you heard of ligament of Stuthus? So what are the structures compressed by that abnormal ligament? Median nerve and then brachial artery. Okay, so that is also remnant of the coracobrachialis. And coming for the variations in the biceps brachii, so biceps is always not a biceps. Okay, there may be 3/8, there may be 4/8, there may be 5/8. Okay, so biceps is always not a biceps. So in this images, in this case reports, you can see the abnormal head of biceps. So you can see the third head of the biceps. The third of biceps here, which is taking origin from the humerus. So what is the normal origin of biceps? From which bone? What is the normal origin of biceps? From the scapula. Okay, so biceps here it is arising from the humerus. So you can see the third head of biceps here. You can see then an additional head. So this is the common fusiform belly, both by elongated short head, and you can see extra belly here. So this is the third head of biceps. And in one case report, some of the authors have reported 5 head of biceps brachii. So the blue arrow you can see here, this is the third head, okay. And red arrow, you can see that is the 4th head of biceps, and green, this is the 5th head of triceps. So additional 3 heads have been reported by these authors. So what is the clinical implication of presence of this additional head of biceps brachii is? They enhance the strength of pronation of forearm and flexion of the forearm, and the additional head crosses only the elbow joint. Okay, so they may alter and the other thing is the additional head, the presence of additional head may alter the course of the musculocutaneous nerve. Coming for the next muscle, that is brachialis, the fibrous band was seen arising from the deep fascia of brachialis and pronator teres, and that had resulted in the compression of the anterior interosseous nerve. That is also been reported. And sometimes the deep part of brachialis it is inserted to the capsule of elbow joint. So that time we called it as capsularis subbrachialis or articularis cubi anterior. That is an anomalous fiber which is inserted to the capsule of elbow joint. And coming for triceps, the variation in the triceps, we all know that subanconius. I would have subanconius, it is given in Chaurash also. So what is subanconius? Some of the fibers of the triceps, it is attached to the capsule of elbow joint and it compresses the cubital tunnel. Okay, so that is called as subanconius. So it causes the compression of ulnar nerve. Okay, that is the importance of the subanconius muscle. We can see this fiber is part of triceps, the deep fibers of triceps, which is inserted to the elbow joint. You can see here. So these fibers are called as subanconius. And sometimes you can also note the sesamoid bone in the insertion of triceps, and that may mimic a fracture. And that sesamoid bone is called as elbow disc or patella cubiti. And coming for forearm, the variations in the muscles of forearm. So we have the flexors and then extensors. And there are many variations seen in the most of the forearm muscles. I have taken only of clinical importance. The first one is pronator teres. There are 15 types of variations has been reported to the pronator teres. the anomalous origin to the supracollar process or to a ligament that connects it to the mielopecondyle has been reported. Okay, the anomalous origin of peroneal teres that is attached to the mielopecondyle has been reported, and in such case, that anomalous fiber can compress the brachial artery and then median nerve, like that of ligament of Struthers. So here you can see in this image, there is only presence of humeral head. There is no ulnar head here. There is only a single head. That is the humeral for the peroneal teres. And the other muscle is called as Ganser muscle. That is nothing but the accessory head of the flexor pollicis longus muscle. Okay, the accessory head is arising from the mielopecondyle of humerus and is inserted to the medial border of the flexor pollicis longus. So that additional head of the flexor pollicis longus is named as Ganser muscle. That is called as Ganser muscle, and is supplied by anterior interosseous nerve. And palmaris longus, it is the most variable muscle in our body, and usually in our routine decision also, we have seen many cadavers where palmaris longus is absent. So palmaris longus is the most variable muscle in the body. It is absent about 20% of cadavers, and palmaris longus is absent more often in the female, especially in the left side, in the both sexes. The another additional muscle in the flexor group is flexor profundus. It arises from the middle one-third of the anterior surface of radius and is entering the palm. So how does this enters the palm is, it is passing through the carpal tunnel. It passes beneath the flexor retinaculum and enters the palm, and it may be inserted to the palmar aponeurosis. So that muscle is called, as you can see, additional muscle fiber which is going to the palm by passing through the carpal tunnel. So this muscle is called as palmaris profundus. So it takes origin from the anterior surface of radius and is passing through the carpal tunnel, and it may be inserted to the palmar aponeurosis. So nerve supply, it is supplied by anterior interosseous nerve, and the clinical significance is, as due to this location, it can result in the carpal tunnel syndrome. So coming for the extensor compartment, there are additional two muscles present in the extensor compartment. So additional wrist extensor may be present in 10 to 24% of population and are more common in the women. These two additional muscles are, one is the extensor carpi radialis intermedius, and other one is the extensor carpi radialis axillarius. So both of them are closer to the longus and brevis muscle, and they have attachment similar to those muscles. And the next one in the supinator, as we all know that arcade of Rossi, that is the fibrous band, thick fibrous band near the origin of this supinator muscle, can compress the posterior interosseous nerve. That is called as arcade of Rossi. And coming for hand muscles, so lumbricals, 19 variations has been reported in the lumbricals so far, and lumbricals may be decreased in number. Either there may be presence of 2 lumbrical, or there may be 3 lumbrical, like that, or sometimes completely absent. Lumbrical may be completely absent, and the other anomalous anomalous of the lumbrical is, it may take origin in the proximally from the forearm itself. Okay, it may originate more proximally in the carpal tunnel or in the forearm, and it may pass either superficial to the flexor retinaculum or maybe to the deep to the flexor retinaculum. So you can see here the additional lumbrical. This additional lumbrical going to the index finger, that is also passing through the carpal tunnel. And in this image also can see the abnormal lumbrical here. And in this case, the infant was having multiple trigger fingers, and during surgery, they have found out that there is an additional lumbrical which is causing that trigger finger. And you can see in this surgical picture, intraoperative surgical photograph you can see here. So there is a presence of lumbrical in the carpal tunnel. It is taking origin from the flexor pollicis longus tendon in front of or prior to the flexor retinaculum itself. So it is passing through the carpal tunnel. And the anomalous insertion of lumbrical has been associated with the camptodactyly. Okay, there's a bend in the PAP joint. So anomalous insertion, it is inserted normally to the radial aspect of the dorsal digital expansion. If it is abnormally inserted, that may result in the camptodactyly. And the accessory slip from the palmaris longus muscle. You can see the accessory slip from the palmaris longus muscle to the thenar muscle, and that does result in the compression of median nerve, once again the carpal tunnel syndrome. And the accessory abductor distae minimi muscle, one case has been reported here. This accessory abductor distae minimi, it is passing through the Guyon's canal. So what is the nerve passing through Guyon's canal? Ulnar nerve, yes. So it may compress the ulnar nerve. And the another case report is the abnormal opponent's digital minimi. So this patient had a carpal tunnel syndrome, and during surgery they have found out that there was an abnormal fiber of opponent's digital minimi which restricted the apportion of little finger, and it is also crossing the median nerve, which has resulted in the carpal tunnel syndrome. And similar to the foot muscle in the dorsum foot, there is a muscle called as extensor digitorum brevis. Similar to that, there may be a presence of the muscle in the dorsum of hand that is called as extensor digitorum brevis manus. We can see this anomalous muscle in the dorsum of the hand. So that muscle is called as extensor digitorum brevis manus. So presence of this muscle may mimic like a soft tissue tumor, and this, how do you diagnose this presence of this muscle is, we ask the patient to extend the wrist and fingers. So during extension, during active extension of fingers, this muscle form a bulge on the dors, whereas other swelling seen in the dorsum of hand, they will be disappear during extension. They will be prominently seen only during flexion of fingers. So that's how we rule out the presence of this muscle or not. So it can also mimic the synovial cyst or exhaustosis, or it may mimic like a neoplastic condition or any inflammatory mass or any infectious mass. Okay. So to conclude, we have seen so many muscles in the variant muscles in the upper limb. There are multiple muscles, there are multiple variations reported in the upper limb. So during dissection, when we see some abnormal fibers, kindly try to document that. We can add to the literature, because we'll be seeing these fibers and we'll be omitting that. We may not be recording that. Okay. So I request all the anatomists to kindly make a note of, if you see any abnormal fibers, kindly make a note of it. When I was going through the reviewing the literature, some persons have reported even the abnormal fascicles of triceps. They published a paper in that. So kindly, if you encounter any variation in the muscle, kindly report that. It will be definitely useful for the academicians, researchers, and especially the clinicians. Thank you all. I thank the organizers, mainly our friend and mentor, Dr. Dhanlakshmi ma'am. She has been always our motivator, starting from our PG life. Thank you, ma'am. I thank you all the organizers for providing me this opportunity. Thank you. Thank you for patient listening.
Thank you, sir, for your wonderful speech. I request the chairpersons to share a few words.
Good morning, one and all. Sir, it was an excellent presentation with very nice dissection images of the muscles, highlighting the variations. I once again thank the Professor and HOD of Thoothukudi Medical College, Dr. Dhanalakshmi, who is well known to me only as Dhanaka. Right from my UG days, என்னை ரேக் பண்ணவங்க இப்போ வரைக்கும் ரேக் பண்ணிக்கிட்டு இருக்காங்க. And my mentor, who I have worked with her in Thoothukudi Medical College for 10 months, which period I treasure a lot. Thank you once again, Dhanaka, for giving me this opportunity. Thank you. Thank you, sir.
So there was a very illustrative talk, and your slides were very descriptive and excellent with the reference for each slide. That was wonderful to look at. And to be very honest, I am hearing a lot of names which I heard in my anatomy days. Thank you so much. And I am sure this will be very useful for my postgraduates. We do a lot of axillary dissections, but I didn't know there are so many variations of muscles in the axilla. Thank you so much.
Thank you. you, sir. Thank you, sir. Actually, I was wondering the presence of all these new muscles. I think it will be new to many of the anatomists also. Thank you, sir.
May I now request Dr. Rakesh Fernando sir, Dr. R. Mugam sir and Dr. Bharati Rani ma'am to felicitate Dr. Arun Kumar sir. I request Dr. N.V. Ganga ma'am, Senior Assistant Professor in Anatomy, to kindly present a memento to Dr. Rakesh Fernando sir. I request Dr. Ganga ma'am to felicitate Dr. Arumugam sir. I request Dr. Ganga ma'am to present a memento to Dr. Bharati Rani ma'am. Over to Hannan and Gladys Cheryl.
We are waiting for our Dean sir to arrive for inauguration. Meanwhile, tea and snacks will be provided. Please remain seated. Please remain seated. Refreshments will be provided here.
மினிட்ஸ் வீடியோ மட்டும் போட்டுட்டு அப்படியே வீடியோவே வேணாம். அதுக்கப்புறம் டைம் கரெக்டாக தானே போய்கிட்டு இருக்கு. ஆமாம் 2 மினிட்ஸ்.
It's 11:06 a.m. To hear your notifications, follow the notification on your phone to turn on notification app. It's 11:08 a.m.
The human body, where the universe of biology weaves the story of existence. Distinguished guests, speakers, professors, batchmates and juniors, today I, Hannan,
and me, Gladys,
take great honor and immense pleasure to extend a cheerful welcome to you all. Your presence makes us very happy. Welcome to the Anatomy CME Anaphysis.
And now, friends, please join us in giving our distinguished guests a cordial welcome. Firstly, let's welcome our chief guest, Dr. M. Jayanti Ma'am, to Anaphysis 2023. Ma'am, please take the dais.
Next, we welcome our Dean, Dr. G. Shivakumar Sir, to Anaphysis 2023. Sir, we request you to take the dais.
Vice Principal inside. Vice Principal inside. Okay. Now we welcome our Medical Superintendent, Dr. R. Padmanabhan Sir, to Anaphysis 2023. Sir, we request you to take the dais.
Next, we welcome our Deputy Superintendent, Dr. P. Kumaran Sir, and Resident Medical Officer, Dr. J. Silas Germany Sir, to Anaphysis 2023. Sir, we request you both to take the dais. Now, let's give a hearty welcome to our esteemed speakers. I would like to welcome Dr. T. Suresh Kumar Sir and Dr. K. R. Arun Kumar Sir to Anaphysis 2023.
Next, we welcome Dr. K. Subha Anandi Ma'am and Dr. S. Satish Kumar Sir to Anaphysis 2023.
We request Dr. V. Dhanalakshmi Ma'am, HOD, Department of Anatomy, Govt Thoothukudi Medical College, to take the dais.
We also welcome the judges of the art competition. We welcome Dr. J. Tadayus Sir, Professor and HOD of Dermatology, Dr. Arasi Rajesh Ma'am, Professor and HOD of Pathology, and Dr. G. Charanya Ma'am, Assistant Professor of Anatomy, to Anaphysis 2023.
Next, we welcome the judges of the poster presentation competition. We welcome Dr. S. Bharadhirani Ma'am, Associate Professor of Anatomy, Govt Sivagangai Medical College, and Dr. G. Angel Velut Ma'am, Professor of Anesthesiology, Govt Thoothukudi Medical College, to Anaphysis 2023. To start off the event, I call upon Mary Winslet, Janani Shri, and Angel Eliza Mary for Tamil Thai Valthu. I request you all to stand up for the same.
நீராறும் கடலுடுத்த நிலமடந்த கெழிலொழுகும் சீராறும் பதனமென திகழ் பரத கண்டமிதில் திக்கனமும் அதிசிறந்த திராவிடனர் திறனாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிலமை திறம் வியந்த செயமறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
Thank you, Mary, Janani, and Angel, for mesmerizing us with your voices. Now I request the dignitaries to light the Kuttuvilakku.
Now, I call upon Dr. V. Dhanalakshmi ma'am, Professor and HOD of Anatomy, to deliver the welcome address.
Hello.
Good morning to everyone gathered here. It's my immense pleasure to welcome you all for this grand academic feast, the Anaphysis 23, Divergence, the variations in the upper limb, which will be an eye-opener for many of us. So I would like to welcome the chief guest, Dr. Jayanti Madam, Director, Institute of Anatomy, Madurai Medical College, for gracing this occasion. As soon as I called, she immediately obliged to it. And she's the first person to come here in the morning. Welcome you, madam. And we welcome our expected Dean, sir, the soft and dynamic person, a man of solutions. Whenever we enter into his room with the problem, we'll come out with the solution. We welcome you, sir. We welcome our VP madam. Actually, she's online. She's not able to attend here. It has been a great support for us from the starting when we said that we are going to planning for a CME program. We welcome madam through online. And we welcome medical superintendent, sir. So he's another person. Actually, every day morning, there will be a tug of war between me and sir to keep the biometric attendance sharply at 8 o'clock in the morning. So we welcome you, sir, for the CME. We welcome Deputy Superintendent, sir, who's a friend of students. And again, he's a great supporter for our department. We welcome you, sir, for this program. And we welcome RMO, sir. Without him, there is no dissection hall. So all the cadavers which we have for the dissection is being procured by RMO, sir. So he used to motivate all the attenders and he used to get us all the cadavers. So we welcome you, sir. And on behalf of our department, I welcome all the speakers, the chairpersons, professors, associate professors, assistant professors, tutors from all the departments, the judges for various programs. Actually, we are celebrating this Anaphysis for the past 1.5 months. And I also welcome all the online participants. Actually, we had a huge round of response for that. Nearly more than 600 registration for this CME. I welcome all my students, the freshers, and the senior batch, without whom we will not be able to do this. And in information to all the HODs of other departments, you can you can start on any program with this batch of students. And I welcome my colleagues, the non-teaching staffs, the workers, the electrician mainly, the camera persons, and everyone for the CME. Thank you.
Thank you, Dhanalakshmi ma'am, for your warm words and hospitality. Now, let's get to know a bit more about our eminent guest.
Our chief guest, Dr. M. Jayanti ma'am, is the director of Institute of Anatomy at Madurai Medical College. She did her MBBS at Madurai Medical College from 1982 to 1988. She completed her MS at Madras Medical College in 2008. Her service spans over 33 years with a teaching experience of 18 years. She has conducted CMEs at Theni Medical College and Madurai Medical College. She has served as nodal officer at Theni Medical College for 2 years. She has conducted DNB exams and has been a DNB examiner for the past 2 years. Her numerous accolades include the Best Doctor Award from Indian Medical Association Theni and Best Medical Service Award from District Collector Theni.
We have our Dean, Dr. G. Shivakumar sir. He has been a backbone to our college by handling matters in a calm and efficient manner. He is a keen observer who responds rather than reacting. He is a very humble person who is easy to get along with. He truly sets an ideal role model for all of us to look up to. We have our medical superintendent, Dr. R. Padmanabhan sir. He's a remarkable personality in the field of pediatrics. He's a methodical and disciplined individual. He's hardworking and is a vital asset to our medical college.
Next, we have our Deputy Superintendent, Dr. P. Kumaran sir. He has been an incredible source of support for the Department of Anatomy. He always looks after the students and helps them during their times of hardships and needs.
We also have a resident medical officer, Dr. J. Silas Jayamani sir. His support to the anatomy department is priceless. He has rendered immense support to the Department of Anatomy by procuring cadavers so that the budding doctors can enhance their prowess in anatomy. It is safe to say that without him, the dissection hall of anatomy won't be what it is today.
Now, I call upon our respected Dean, Dr. G. Sivakumar sir, to address the gathering.
Respected Chief Guest Dr. Jayanti, respected Medical Superintendent Dr. Padmanabhan sir, Deputy Superintendent Dr. Kumaran, Resident Medical Officer Dr. Silas Jayamani sir, Head of the Department of Anatomy Dr. Dhanalakshmi Madam, all the eminent faculties, professors, associate professors, assistant professors, tutors, and all the students, a very good morning to one and all. It's been a great pleasure and honor to be in this CME program of Anaphysis. That is the anatomy. The first thing I came to my mind after some thinking is A for எல்லாரும் படிச்சிட்டு இருந்தது ஸ்கூல்ல வேற இங்க மெடிக்கல் ஸ்கூல்ல A for anatomy is the what that came to my mind. I wrote there. So yes, always in a medical field, anatomy stands first. And these programs like CME, as I earlier have addressed, is very, very important because it is a learning process throughout your life until your grave. So another one, as I said, another one book that comes to my mind is the Gray's Anatomy, which depicts all the variations also in that book, which we read in our times. Now I don't know what's going on. And another book is Brown's Anatomy, that another one anatomy which we saw in our postgraduate period. These textbooks gives a clear illustrations of what anatomy is and how we learn. And the surgeons, if they remember this, we used to learn at that time the clinical anatomy, the McGregor, I think. McGregor's clinical anatomy. These things we come across during my days. This is my days. Madam, the topics எல்லாம் போட்டுருந்தாங்க பார்த்தேன். I'm just not familiar with it. How she selected this topics, பேர் வச்சாங்கன்னு எனக்கு தெரியல. Firing and wiring. எல்லாமே வந்து பார்த்தீங்கன்னா ஃபயரிங் இன் மசில் அண்ட் மேஸ், ஸ்கெலிட்டல் காண்ட்ரம், மிஸ்டிஃபை தி வேம்பையர், எல்லா பேரும் பார்த்தீங்கன்னா இங்கிலீஷ் மூவிஸோட நேம் மாதிரி இருக்குது. நான் ஃபஸ்ட்டு படிக்கும்போது அப்படி தான் எங்கேருந்து இதெல்லாம் பிடிச்சாங்கன்னு தேடி கூட பார்த்தேன், கிடைக்கல. பட்டு இந்த வேம்பையர் பேர் மட்டும்தான் கிடச்சிது. ஸோ இந்த பிளட்டு வேம்பையர் அப்படி இப்படின்ட்டு. ஸோ தீஸ் ஆர் ஆல் கம்மிங் டு மை மைண்ட். இட்ஸ் வெரி நைஸ் திங் மேடம் பேரை செலக்ட் பண்ணியிருக்கிறது. ஸோ எவ்ரிபடி லேர்ன் திஸ். இட்ஸ் வெரி இம்பார்ட்டன்ட் டாபிக். அண்ட் த வேரியேஷன்ஸ், நார்மல் anatomy is different and the variations is very much important. When you come across, when you ask our surgical colleagues, they will say the variation plays how difficult and different it is to treat a patient. So variations always should be kept in your mind. ஒரு சஸ்பிஷியஸ் ஆஃப் மைண்டில் இருந்தால் தான் அந்த வேரியேஷனை கண்டுபிடிக்க முடியும். ஸோ யூ லேர்ன் திஸ், ஹாவ் அன் ஐடியா, புட் இன் டு யுவர் ப்ராக்டிஸ் வென் இன் த ஃபியூச்சர். ஐ விஷ் கிராண்ட் சக்ஸஸ் ஃபார் திஸ் அனாஃபிசிஸ். தேங்க்யூ மேடம்.
Thank you, sir, for your encouraging words. Now we invite our chief guest, Dr. M. Jayanti ma'am, to deliver the chief guest address.
respected Dean Dr. Sivakumar sir, respected Vice Principal Madam Dr. Kalaivani, and respected Medical Superintendent sir Dr. Padmanabhan, respected Deputy Superintendent, my UG batchmate Dr. Kumaran, respected RMO Dr. Selas Jayamani sir, and respected HODs, professors, faculties and PGs from various departments through online and offline, and my dear undergraduate students, a warm and pleasant morning to all. Really, I am so proud and privileged to be here today, and I would like to congratulate Dr. Dhanalakshmi, Professor and HOD of Thoothukudi Medical College and her team for inviting me and giving me this great opportunity. Thank you, ma'am. Once, some few years before, or 1 decade, conducting these type of academic activities like CME workshop, everything were possible, especially in non-clinic department, that too in anatomy department, were possible in colleges situated in and around Chennai, where more private medical colleges are there. But now the situation is not like that. Everywhere, all over Tamil Nadu, including newly started colleges, they are regularly conducting this. Telling about our non-clinic department, our anatomy department. So they are conducting all these workshop and CEP, continuing education program, regularly. Really, I am very happy, and it's very much appreciated one. Thank you for all anatomists and faculties, PGs of anatomists for conducting these type of activities. Keep going like this. And regarding today's topic, the title, as our dean said, the topic itself, title name itself, very amazing and attracting one, Anaphysis and Divergence. It's a very nice title, and once again I congratulate Dhanalakshmi madam. And usually this CEP எல்லாமே என்ன பண்ணால் ஒரு ஹெட்டிங் மட்டும் வைப்பாங்க. ஃபார் எக்ஸாம்பிள் brachial plexus ஆர் nerves in upper limb like that. ஒரே கல்லில் 4 மாங்காய். அதே மாதிரி எல்லா டாப்பிக்கும் ஒரே இதில் எடுத்துட்டாங்க. ரியலி இட்ஸ் a great effort taken by this anatomy department. And these CEP really, as previous speakers said, very useful for PGs, postgraduates, who are going to do so many theses and paper publication, everything. So the variations are very well delivered by the previous speakers. Really, definitely it might be useful for postgraduates doing thesis and paper publication, everything. And for undergraduate students, anyway, after completing your MBBS, definitely you are going to do specialty, master degree and super specialty, everything. So from now onwards, first year is the basic, foundation stone, all 3 subjects, anatomy, physiology, biochemistry. So you grasp all these knowledges, which would definitely useful for your future career. So make use of them. Then I congratulate those who I enter into this noble profession, 2023 batch, after a brief period of battle, neat battle. ஸோ அதுக்கப்புறம் இங்கே வந்திருக்க எல்லாருக்கும் என்னோட வாழ்த்துக்கள், wish you all the best. Then for 2022 batch, university examination has come. So November 1, we are going to write your theory exam. Wish you all the very best. Study well, prepare well. And I forgot about speakers and chairpersons. And once again, I welcome all these speakers and chairpersons who are delivering their speech in a very wonderful way. Really, I am very happy to be here and knowing about all these things, variations in muscles, nerves, everything in upper limb. And once again, I congratulate the team of anatomy under the leadership of Dr. Dhanalakshmi, Professor and HOD of Anatomy, for giving me this opportunity. And I wish all the success of this program. Thank you so much.
We express our heartfelt gratitude for your words, ma'am. Next, we invite our Medical Superintendent, Dr. R. Padmanabhan sir, to share his thoughts.
Very good afternoon, one and all. Respected Professor Jayanti Madam, respected Dean Sir, respected Deputy Superintendent, respected Vice Principal Madam, respected RMO Sir, respected Professor and HOD of Anatomy, Dr. Dhanalakshmi Madam, respected all other HODs and faculties. So this is a pleasant day for us. So as an undergraduate, as Dean Sir had said, A stands for not apple, it is anatomy. So really it is a very enthralling feel to go through, because நம்ம படிக்கும்போது அந்த அளவுக்கு ஆர்கன்லாம் பார்த்துருக்க மாட்டோம். anatomy dissection போது தான் நிறைய பேர் மயக்கம் போட்டுலாம் விழுந்திருப்பாங்க dissection ஹாலில். ஸோ இட் இஸ் ஒன் ஆஃப் த ஃபேசினேட்டிங் ஃபீல். And I used to remember Professor Hariharan, who taught us anatomy in those days. He is one of the stylish personality. He used to draw the diagrams, line diagrams, okay, and he used to remember all our names alphabetically. Instead of going through the attendance, he memorized that, and he used to call by name, and whenever we fall asleep in the class, he will raise us and make us to attend. So that is one of the great teacher. He is no more. Probably he has worked as a director of Madurai Medical College also. So he is one of the main important role model. Generally, for undergraduates, these basic sciences like non-clinical sciences, they are shaping to the clinical sciences. So they taught the students about the punctuality, respectfulness, and obedience. All these things are shaped by these teachers, and we clinician, once the molded students வந்து நாங்கள் டேக் ஓவர் பண்ணிவிட்டு நாங்கள் நல்ல ரிசல்ட்ஸ் கொடுக்குறோம். ஸோ ஆல் த கிரெடிட் ஷுட் கோ டு த undergraduate, that is basic sciences teachers, and they very keenly trying to implement the NMC activities like mentorship program. All the programs by the NMC is implemented in the college, then only slowly it is taken over by the clinical people. So I wish this CME a grand success, and all the students should attend till the end and gain the knowledge and spread the knowledge to the others. Thank you.
Thank you, sir, for those thought-provoking words. We now welcome our Deputy Superintendent, Dr. P. Kumaran, sir, to speak a few words.
Respected Chief Guest Dr. Jayanti, respected Dean Sir, MS Sir, RMO Sir, and all the professors and associate professors and dear students, and Department of HOD Anatomy, Dr. Dhanalakshmi ma'am. Really, it's very amazing. As you all know, it is very difficult to conduct a non-clinical department for such a great event. I am really amazed to see an aspirants of anatomy so much involving this CME, and as you all know, as a medical student, everybody had to enter the anatomy hall, because 8 o'clock we have to get up. In those days, there would have been severe ragging also. We used to sleep or may not sleep in the night. ஸோ 8 மணிக்கு எந்திரிக்கலாம் ரொம்ப கஷ்டமாக இருக்கும். ஸோ அனாட்டமி ஹாலுக்குள்ளே போகிறதே வலிஞ்சிக்கிட்டே தான் போவோம். 10:30 தான் குளிக்கவே வெளியில் வரும் மதுரை மெடிக்கல் காலேஜ் எல்லாம். ஸோ அந்த அளவுக்கு டஃப்பாக இருக்கும். அண்ட் ரிகார்டிங் டாக்டர் ப்ரொஃபஸர் ஜெயந்தி, and you know how the students who have studied at Madurai Medical College would have know how the anatomy dissection hall would have been. It was like just a stone and a paste of cement. ஸோ அது வந்து போன் அண்ட் ஜாயிண்ட் மட்டும்தான் இருந்தது. இப்போ ஆஃப்டர் having a post of a director as an professor of HOD, director of Anatomy Institute, and she has really metamorphosed the Department of Anatomy to a circulatory system. And இப்போயும் நாங்கள் அனாட்டமி ஹாலுக்குள்ளே போகிறதுக்கு ஜெயந்தியை பார்க்க போகிறதுக்கு பயப்படுவோம். ஏன்னா போனோடனே இதுக்கு கபோர்டு பண்ணணும், இதுக்கு அது பண்ணணும், இது பண்ணணும், நீங்கள் ஏதாவது டொனேஷன்ஸ் கொடுங்கன்னு கேட்டுக்கிட்டே இருப்பாங்க. அண்ட் ஆஸ் அன் அலுமினி வி ஹவ் டொனேட்டட் ஸோ மச் டு ஹர் நீட்ஸ் அண்ட் ரியலி as ஒரு இன்ட்ரெஸ்ட் இருக்கும். She has got a great enormous effort in collecting the money and uplifting the department of anatomy. I know the anatomy department, it has been as modern as westernized department. So I am really thankful to my batchmate Dr. Jayanti, who has really metamorphosed the department of anatomy. Thank you, madam. And I thank Dr. Dhanalakshmi madam. She has got a very great and Himalayan interest in uplifting the department of anatomy. And I thank all the department of anatomy professors, associate professors and tutors and students who have been so much obliged to her request, and really a beautiful CME. Thank you. All the best for the CME.
Thank you, sir, for your words of inspiration. Now we have the felicitation session. I request Dr. Dhanalakshmi ma'am, HOD of Anatomy, to present the memento to our Dean, Dr. G. Shivakumar sir.
And just one small announcement, and it is very happy to announce that Madurai Medical College Dissection Hall is the longest and biggest anatomy hall throughout Asia.
I request Dr. Dhanalakshmi ma'am to present the memento to our chief guest, Dr. M. Jayanti ma'am. Thank you, Dhanalakshmi ma'am.
Now I request Dr. N.V. Ganga ma'am, Senior Assistant Professor of Anatomy, to present the memento to our Medical Superintendent Dr. R. Padmanabhan sir. Thank you, Ganga ma'am.
Now I request Dr. R. Kalamudrasi ma'am, Senior Assistant Professor of Anatomy, to present the memento to our Deputy Superintendent, Dr. P. Kumaran sir. I request Dr. Kalamudrasi ma'am to present the memento to our Resident Medical Officer, Dr. J. Silas Jayamani sir. Thank you, Kala ma'am.
Next, I invite our Dean, Dr. G. Shivakumar sir, to felicitate our speakers. I welcome Dr. K. Arun Kumar sir to receive the felicitation. I welcome Dr. K. Subha Anandi ma'am to receive the felicitation. I welcome Dr. S. Satish Kumar sir to receive the felicitation. Thank you, sir.
Now we call upon our chief guest, Dr. M. Jayanti ma'am, to felicitate the judges. I welcome Dr. Arisi Rajesh ma'am to receive the memento. Dr. S. Baladirani ma'am to receive the memento. I welcome Dr. G. Serenia ma'am to receive the memento. Thank you, Dr. Jayanti ma'am.
Now we invite Dr. Dhanalakshmi ma'am to felicitate the anatomy faculties. I welcome Dr. N.V. Ganga ma'am to receive the memento. I welcome Dr. R. Kalamutharasi ma'am to receive the memento. I welcome Dr. G. Sharanya ma'am to receive the memento. I welcome Dr. B. Regina Mary ma'am to receive the memento. I welcome Dr. Fatima Musfira ma'am to receive the memento. I welcome Dr. N. Nadine ma'am to receive the memento. Thank you, ma'am. Now, to congratulate our students for their sheer hard work and dedication, we have the prize distribution session for the competitions conducted across the last 2 months. We welcome our Dean Sir to give away the prizes.
First, we have the prize distribution for the art competition conducted by the Department of Anatomy on 25th of July 2023. The third position is held by Dr. Amrita Shrivani ji of 2022 batch. Second prize is backed by Dr. Malavika M of 2021 batch. And the first prize goes to Dr. Gladys Shell ji of 2022 batch. I request our Chief Guest, Dr. M. Jayanti ma'am, to felicitate Dr. J. Tadayu sir.
Next, we have conducted the prize distribution for the quiz program War of Words, conducted by the Department of Anatomy on 8th of August 2023. The third prize is backed by Dr. S. Kausalya of 2020 batch, Dr. M. Gayatri of 2021 batch, and Dr. M. Mahalakshmi of 2022 batch. The second place is held by Dr. M. Uma Maheshwari of 2020 batch, Dr. Nafia Naviza of 2021 batch, and Dr. S. Muthuselvi of 2022 batch. Prize goes to Dr. Lynette Jose of 2020 batch, Dr. Aditya Vishwaveena of 2021 batch, and Dr. R. Narasimhan of 2022 batch.
Gratitude makes sense of our past, brings peace for today, and creates a vision for tomorrow. Now we welcome Dr. N.V. Ganga Ma'am, Senior Assistant Professor of Anatomy, to deliver the vote of thanks.
Respected dignitaries on the dais, professors, associate professors, faculties and postgraduates of all departments of Thoothukudi Medical College and other colleges, Tamil Nadu Medical Council Observer Dr. Marimuthu sir, online participants of various colleges throughout the nation, and my dear undergraduate students, a very good morning to one and all. On behalf of Anatomy Department, Government Thoothukudi Medical College, myself, Dr. Ganvi Ganga, takes an immense pleasure to propose vote of thanks on this memorable medical education session. I would like to thank our chief guest, Dr. M. Jayanti Madam, Director, Institute of Anatomy, Madurai Medical College, for accepting our invitation and gracing the occasion. Thank you, ma'am. I express my sincere gratitude for our beloved Dean Sir, Dr. G. Sivakumar, for his guidance, kindness, encouragement, hospitality, and persistent support for this program. Thank you, sir. I extend my gratitude to Vice Principal Madam, Dr. V. Kalaivani, today Vice Principal Sir, Dr. T. Jayamurugan, Medical Superintendent Sir, Dr. R. Batmanaban, Deputy Superintendent Sir, Dr. P. Kumaran, Resident Medical Officer Dr. J. Silas Jaimani sir for their motivating words and support. Thank you. My heartfelt thanks to all eminent speakers, chairpersons, judges of various competitions for their excellence in delivering academic feast, quenching our knowledge thirst, and enabling us to explore and escalate. I express my heartfelt thanks to all head of departments and faculties of Thoothukudi Medical College for their encouragement and support. And I would like to thank our beloved organizing secretary, professor and head of department, Dr. V. Dhanalakshmi Madam, who worked round the clock, and for her compassion and in commitment. I extend my sincere thanks to all my colleagues who worked with me, members of organizing committee, for their untired work and coordination in all arrangements to make this event successful. I would like to thank online participants for their enthusiasm and support. And I extend my thanks to Elsevier and JP Publisher for their contribution, Assistant Engineer of Electricity Board Department for uninterrupted power supply, technical team, printers, electrician Mr. Prabhagar, media team and audiovisual aids team, MBBS students of all phases, participants of various competitions, caterers, crystal supervisors, workers. Last but not least, a big thanks to all 150 students of first MBBS 2022 batch. Who have literally made this day possible by providing valuable support and making today's event a grand resounding success. A special thanks to Anatomy Arubugam, free final MBBS student, for his extreme supports from the beginning and throughout the program. Once again, I thank all for your support for this Anaphysis 2023 Divergence of Upper Limb Hybrid Continuous Education Program. I thank our organizing secretary, professor and head of department, Dr. V. Dhanalakshmi Madam, for giving me this opportunity. Have a good day.
Now we have an exclusive video for the anatomy department from the batch of 22. Request the dignitaries to join with the crowd. Let's begin. We congratulate Tharnidharan and George and Co for this amazing video.
Moving on to the next session, may now request Dr. K. Subba Ananthi Ma'am, Professor of Anatomy, Indira Gandhi Medical College and Research Institute, Puducherry, to kindly come to the podium to deliver her session on variations in the bones of upper limb, skeletal conundrum.
It's an honor to introduce our esteemed chairpersons of this session, Dr. Anita Ma'am, Dr. C. Pavalan Sir, and Dr. M. Sita Lakshmi Ma'am. Dr. Anita Ma'am is currently the Professor and HOD of Anatomy in Kanyakumari Government Medical College. Dr. Pavalan Sir is the Professor and HOD, Department of Orthopedics in Government Medical College. Dr. Sita Lakshmi Ma'am, Professor and HOD of Forensic Medicine in Government Virudhunagar Medical College. I request the chairpersons to introduce the speaker. Over to the chairpersons.
Good morning. Government Thoothukudi Medical College, respected faculties, respected Dean Sir, and the administration team, respected faculties on the dais and off the dais. First of all, I would thank Dr. Dhanalakshmi Ma'am to provide me a chance as a chairperson here. The speaker, Dr. K. Subba Ananthi Ma'am, Professor, Indira Gandhi Medical College and Research Institute, with a teaching experience of 18 years, alumni of Tirunelveli Medical College and post-graduation at Madras Medical College. At present, she is working in Indira Gandhi Medical College and Research Institute, Pondicherry, member of Medical Education Unit, coordinator of MAU, member of Student Wellness Center, Library Committee, one of the gem of Indira Gandhi Government Medical College. Nothing more to praise her. Nearly she has 35 publications, memberships in nearly 4 to 5 associations, very much interested in anthropometry, anthropology, medical education and embryology. Over to you, ma'am.
Thank you, ma'am. Respected Dean, respected Vice Principal, sir, respected RMO, sir, MS, sir, other professors of various departments, my seniors, students, other faculty of Thoothukudi Medical College, and other participants through online. A very good morning to one and all. So before entering into the session, I would like to thank Dr. Dhanalakshmi, Professor and Head Department of Anatomy, Thoothukudi Medical College, for giving me this wonderful opportunity. And I would like to congratulate her for taking this topic. This is a very rare topic to say, that is choosing variations in the upper limb. So my session is about variations in the bones of upper limb. So this is named as skeletal conundrum. So variation in the bones. So objective of this session is to correlate the anatomical variations to its embryology, the physical appearance and closure, as well as the phylogenetic changes. So come, join hands with me to explore the world of variations in the bones of upper limb. So in phase 1, students, they handle the dry human bones. So they study the normal anatomy. Along with that, what to look for in dry bones. So one, any change in the shape of the bone, any change in the size of the bone. Look for the presence of accessory foramina. Look for anomalous articular facets. Look for abnormal protuberances or prominences which could be due to ossification of any ligaments and any variation in the developmental, that is ossification defects. As you enter into phase 2 and phase 3, you will come across radiological images in ultrasound. So when you look at these images, look for the variations like whether that particular bone is present or not. If present, is it hypoplastic or dysplasia? And look for its normal position, whether it is present in the normal place, as well as look for the numbers, whether it is duplicated. So these are the possible variations. And for our convenience, my convenience, I have divided this into 2 topics or 2 categories. One is the bones of pectoral girdle, which includes the clavicle and scapula. And the second one is bones of free upper limb. That is the appendicular skeleton. So we look at the clavicle, variations in the clavicle. So number 1 denotes the variation in the shape. So here there is an increased concavity in the lateral 1/3 of the clavicle. So when there is an increased concavity, we give the term as lateral clavicle hook. So LCH, so lateral clavicle hook is nothing when the clavicle lateral 1/3 presents with increased concavity forwards. So you can see that. So Igwal, he measured this variation by taking midpoint in 2 ends, both the medial end as well as the lateral end, that is the sternal end and the acromial end. Midpoint was taken and connected the 2 lines, which gives A, which is nothing the length of the clavicle. And another midpoint on the maximum concavity. So from that, draw a line to A, that gives the B. So this gives the index of angulation. And that is calculated by B by A into 100. The normal measurement is somewhere around 5. So 5 centimeter. So if it is above 5, that is 6 to 10, it comes under borderline category. And above 12 centimeter, then it comes under lateral clavicle hook. So lateral clavicle hook can be associated in trisomy 8 or in Hall-Torum syndromes or TAR syndrome, that is thrombocytopenia absent radius syndrome. So this can be associated with other syndromes also. So coming to the next variation, that is look for any accessory foramina. So in clavicle, apart from the nutrient foramina, there can be a canal or a notch for the passage of supraclavicular nerve. So this supraclavicular nerve, the intermediate branch, it gives 3 branches, medial, intermediate and lateral branches. Among that, the intermediate branch of supraclavicular nerve passes through this canal, and usually it is present in the junction of middle 1/3 and lateral 1/3 of clavicle. So this can produce compression. Very rarely it produces compression. So supraclavicular nerve is a branch that arises from the cervical plexus with a root value of C3 and C4. So with an incidence of 2 to 6% of individuals. This is a radiological image showing the supraclavicular canal foramen. So this might mimic as a minute osteolytic lesion, should not be mistaken for it. This is an interesting anomaly. Canals in clavicle, not a single canal, presented with 3 canals This was a report given from Israel. So here, this is a superior surface. So in superior surface, there was a canal of about 11 millimeter, and this is the anterior surface of the clavicle with two canals. So one was present medially, which was around 20 millimeter, and the other one was little lateral to it, which was around 17 millimeter. So these three canals, they were communicating with each other. They took X-rays, and you can see they were communicating with each other. The margins were smooth, so it doesn't show any pathological one. And the diameters, it coincided with the vessels. So what they concluded was, since it was a dry bone, what they concluded was any one of the vessels, either it could be a subclavian vein or an artery that would have passed through that. So here, if it would have been a subclavian vein, then in the superior surface, it would have been the external jugular vein, which terminates into the subclavian vein. If it would have been an artery, then it would have been an origin of thyrocervical trunk, which is a branch that arises from the first part of subclavian artery. This is for the third variation. So number 3 denotes the anomalous articular facets present. So normally we don't have any coracoclavicular joint, we have only the ligaments. So sometimes there can be a joint formed, it's a synovial joint. So you can see here, this is a coracoclavicular joint. So with incidence of around 3%, it's more common in Asians. Usually it's an incidental finding. And the distance between the coracoclavicular is usually less than 13, that is between 11 to 13 centimeter. When this joint is present, it will be narrow. This is, you can see in the clavicle, both coracoclavicular as well as costoclavicular joint. So in addition to the coracoclavicular, costoclavicular joint is present, that is in the medial end. It articulates with the first costal cartilage. So incidence is around 2.6%. This is an interesting anomaly, that is congenital pseudoarthrosis, a defect in the union between the ossification centers. So the baby usually presents with a lump in the neck region, and this lump gradually, you can see, lump can be noticed. So here, there is a defect in the clavicle. Usually it is between the middle 1/3 or junction between the middle 1/3 and lateral 1/3. So you have two ends of the clavicle. It might mimic a fracture, but remember there is no callus formation. So that gives you a clue that it is not a fracture. So incidence is around 10%, and commonly reported on the right side. In one case, it was reported on the left side, but that case was associated with dextrocardia. And this is usually presented with the right-sided, highly placed subclavian artery. So that subclavian artery can cause or defect in the ossification centers union. Because you know, clavicle, it's a dermal bone, except for the medial and the lateral ends. So that we have two primary centers of ossification. Clavicle has so many peculiarities. One among them is ossified by two primary centers, and these two centers, they fail to unite. So one another case, along with congenital pseudoarthrosis with bifurcation. So you can see the two ends bifurcating. Again, this is an incidental finding. So sometimes a patient can present with the pain, especially during overhead activity. And this patient actually, she presented with C8 compression also. Cleidocranial dysplasia, a defect in the ossification here. Congenital absence of clavicle. So bilaterally it is absent, you can see. No clavicle here. Usually horses, they don't have clavicle. So here, the two shoulders can be approximated in the midline. The patients Again, it's an incidental finding. They go to dentist for dental problems. That's how they were identified. In addition to absence of clavicle, they can present with metopic sutures, delayed closure of fontanelles sutures, all these can be presented. So again, incidence is very rare, 0.5 per 1 lakh population. This is also called as Mary-Santon syndrome. So this syndrome, the cleidocranial dysostosis was coined by Mary and Santon. This is to show supernumerary teeth. It is also called as dento-osseous hypoplasia or dysplasia. It presents as an autosomal dominant disorder. So usually they go to a dentist. Why this happens is a mutation in RUNX2 genes. So RUNX2 is responsible for the membranous ossification. So when there is a mutation in that, failure of formation of clavicle associated with anomalies of skull as well as teeth. So this is duplication, partial duplication. So Golthamar, he only named this partial duplication as os subclavicular. So os subclavicular was the first name given for duplication or partial duplication in 1957. Later on, it was called as bifid clavicle by twig. This again goes with clinically insignificant. There is no significance of partial or complete duplication. So duplication, this is bilateral, you can see bilateral duplication of clavicle. This is either associated with the duplication of a coracoid process or duplication of acromion process, carries no clinical significance. So you can see the bifurcation, complete bifurcation, and it is bilateral. So coming to the next bone, that is scapula. So scapula, so first one refers to the change in the shape. So it's called as scaphoid scapula because of the concavity vertebral border, or the medial border is concave because this ossifies from a separate center. So you have a separate center of ossification, and when it fails to form, it leads to scaphoid scapula. So this is the ossification. You can see in the center, again the primary center, it develops into a scapula is a bone with both dermal as well as the cartilaginous ossification. So this is central part. And here you can see the vertebral border that ossifies from a second center, separate center. When it fails to ossify, then it leads to scaphoid scapula. So second one is to look for the accessory foramina. Already Dr. Arun Kumar as well as Dr. Suresh sir has said about this, that is about the suprascapular notch. So suprascapular notch is converted into a foramen by the superior transverse scapular ligament. When this ligament ossifies, that canal, the notch is converted into a canal. So through this canal passes the suprascapular nerve, which leads to entrapment. Suprascapular nerve entrapment. Again, with the incidence of 12.5% it goes on. So you can see the bone with the suprascapular foramen, and this is an X-ray showing the suprascapular foramen. So later on they reported with the foramen, and in addition to that a notch was also present. So they were wondering what it could be. It could be, they considered it could be due to the bifurcation of the superior transverse scapular ligament. Then later on a case was reported with double suprascapular foramen. So again they were wondering about that, and then they came to a conclusion that there exists one another ligament called as anterior coracoscapular ligament on ossification can produce this double suprascapular foramen. So this is the anterior coracoscapular ligament on ossification produces this double suprascapular foramen. This was an interesting case. Fourth one is abnormal protuberances. Again, we have the coracoacromial ligament ossification. So this coracoacromial ligament ossification This, you have to rule out renal failure because of increased calcium level leading on to calcium deposition. Rule out trauma also. This becomes a part of shoulder impingement syndrome. So this is to show the coracoacromial ligament which ossifies. Yes, this is abnormal protuberances. Again, in the supromedial angle, we have the levator scapulae muscle attached. So again, that part can produce Lushka's tubercle. Again, similar to the insertion of this teres major muscle, that can also produce teres major processes. This is an important anomaly, that is os acromial. So failure of fusion of these ossification centers of acromion process leads to os acromial. This carries more clinical significance. So you can see the acromion process ossifying by either 2 to 3 ossification centers. We call it as mesoacromion, metaacromion, and basiacromion in the basal part, preacromion in the front part. So when this fail to unite, it leads to os acromial, and the commonest type is the meta or the meso, junction between the meta and mesoacromion. Starts fusing by 18 to 25 years. So before that, before 18, you should not commit this as os acromial. So wait till the age of 25 years. So os acromial, whenever it is present, you have to wait and watch for any shoulder impingement syndrome because of its instability, highly mobile. So the X-ray showing the os acromial. 8% gives you the incidence best viewed in the axillary view. That's an axillary view showing the os acromial. It might mimic avulsion fracture. Okay. Again, look for the callus formation. Might give shoulder pain later on, if not now. And again, as I told you, it carries a risk of subacromial impingement because of its higher mobility. So os acromial, whenever you come across, you have to be careful about it. As a CT image showing the os acromial, usually between the meta and mesoacromial center. This is a scapula showing multiple osseous deficiencies. Glenoid dysplasia. This glenoid cavity ossifies from 2 centers, 2 ossification center. One is from the subcoracoid center, and the other one is from the inferior glenoid ossification center. This inferior glenoid ossification center is a horseshoe-shaped center. So having 3 centers uniting to form inferior glenoid center. So they fuse by the age of 18 years. Usually it is the horseshoe-shaped inferior ossification center fails to form, which leads to glenoidal dysplasia. It can be associated with prominent acromion process and coracoid process, which contributes that, and it might take over the increased concavity. Presents with 18% of incidence. Yes, one another interesting anomaly, that is the Sprengel's deformity. So Sprengel's deformity results in when there is a failure in descent of the scapula. So by 5th week it starts to form, and by 12th week it has to come to its original position. When it fails to descend, it gives rise to Sprengel's deformity. Even though the deformity is named after Sprengel, it was first reported by Eulenberg. But Sprengel, he reported 4 cases and he proposed a mechanism. That's why it was named after Sprengel. So in Sprengel's deformity, you can see a scapula during development, it develops opposite the cervical spine C4 and C5. Later on, then it descends downwards. So when it fails to descend downwards, it leads to Sprengel's deformity, and in these cases, usually the scapula shape will be abnormal. Sometimes there can occur a fibrous band, or an ossification can occur, which we call it as omovertebral bone, which exits between the scapula, superior medial angle of scapula and the spine of C4 or spine of C5. So when it is a fibrous band, it will not be noticed much. When it is a bone, we call it as omovertebral bone. So this is omovertebral bone. So in correction procedure, they first release this. So this is to show the formation and migration. By 5th week, it will be opposite to spine of C4 and C5. Slowly, it descends downwards and come to the position of between T3 and T4. So here, for radiological, there was a classification proposed by Govt as grade 1, grade 2, grade 3, depending upon the position of supromedial angle. So when the supromedial angle of scapula is between T2 and T4, it is called as minor, or the grade 1. Grade 2 is between T2 and C5. Grade 3 is a severe malformation with supromedial angle above C5. That is complete descent failure in descent of scapula. Yes, cases have been reported. Hardly 3 cases were reported for duplication of scapula. So you can see here, so this scapula actually articulated with clavicle, whereas the scapula which is present below formed the joint, shoulder joint. So this is a lateral view to show the 2 scapula. So moving on to variations in the bones of free upper limb. So we divide it into developmentally the stylopod, the zeugopod, that is the forearm, and the arthropod, that is the limbs and malus. So coming on to humerus, that is looking for an anomalous variation in the foramen, the supratrochlear foramen. It's commonly reported. It goes with the, actually Dr. Dhanalakshmi ma'am, myself, we have done so many studies on this supratrochlear foramen. Incidence goes up to 35% and more. This is normally present in hyenas, dogs, because of the posture in handling the food. The pattern, increased extension, perforates and produces a foramen. The clinical significance here is, whenever the humerus presents with the supratrochlear foramen, it is associated with narrowing of the medullary canal. So medullary canal narrowing will be present. So here again, in supracondylar fracture, when they come across this foramen, they have to be careful in the nailing. So antegrade nailing is preferred more than the retrograde nailing, medullary nailing. So this is to show you the supratrochlear foramen should not be mistaken for a lesion, osteolytic lesion or osteocystic lesion. So some foramens, you can see minute foramina later on joining together to form a single supratrochlear foramen. This is another protuberance from the lesser tuberosity. So you have between the lesser tuberosity and the greater tuberosity, we have a bicipital groove through which the long tendon of biceps passes. So there can be a protuberance arising from the lesser tuberosity and encroaching into the bicipital groove. So when this encroaches into the bicipital groove, naturally it tendencies to displace the tendon of biceps. As a result, it can lead to tenosynovitis or tendinitis of bicipital groove. So this is to show you the supratubercular ridge. Holinshed shows huge variation in the presentation of supratubercular ridge with the presence of incomplete, complete, spar formation, all this they have done. Yes, this was an interesting anomaly to come with that is ossification of transverse humeral ligament, the ligament which stretches between the greater tuberosity and lesser tuberosity, which forms a tunnel for the passage of the long tendon of biceps. This has ossified and it has named after Brody as Brody's ligament. So usually they present with tendinitis because of the constant pressure. Deltoid process, as Dr. Arun Kumar sir said about the extensive origin of the deltoid and insertion, some variations in the insertion of deltoid. So that could produce, instead of deltoid tuberosity, it can produce an extensive prominences and it is called as deltoid process. So when deltoid process is present, it should not be mistaken as a pseudotumor. It mimics as a tumor. So it's called a pseudotumor deltoid, carries no clinical significance, but it is a normal variant. Supracondylar spur carries more clinical significance. So this supracondylar spur from the supramedial surface, it's present as a projection and it approaches towards the medial epicondyle. You have attachment of a ligament to it that is called the Struther's ligament. When this Struther's ligament is present, underneath the Struther's ligament you have the passage of median nerve and brachial artery. So compression of these two structures are possible whenever there is supracondylar spur. So this might mimic as a cartilaginous exostosis in an X-ray. So whenever come across the supracondylar spur, again you have to expect these two compressions. It can present with median nerve compression or brachial artery compression. It's not working now. Next slide, please, ma'am. It's not working. This is to show you the Struther's ligament, named after the great anatomist John Struthers. So this gets attached to the medial epicondyle. Yes, this is congenital humeroradial synostosis. When it is a pathological union, we call it as ankylosis, but developmental, we call it as synostosis. So humeroradial synostosis is common compared to the humero-ulnar synostosis, that is rare. So elbow will be flexed with a fixed flexion at 30 degree. So you can see here. It can be associated with ulnar hypoplasia or aplasia of ulna. So it could be due to the bony type or it could be due to joint type. So what could be the reason behind it is there will be initially mesenchymal condensation. So following the mesenchymal condensation, it leads to cartilaginous precursors formation and they form the chondrocytes, they form the cartilage enlarge. So here the chondrogenesis starts from proximal to distal passion. So here we have transcription factors HOXA-A, that is 9 to 13. So any mutation in this, there will be formation of interzone formation which gives rise to the joint. So any mutation in these transcription factors, there will not be any formation of interzone area. So what I have encircled is the interzone area. Usually there will be formation of interzone area. As a result, a joint will be formed between two bones. When it fails to form interzone area, it leads to synostosis. So congenital fusion. Following humeroradial, again this is a rare one, humero-ulnar synostosis, less than 1 in 10 million population. So you can see the union between the humerus and an ulna. This is radio-ulnar synostosis. This becomes, you can see here. So radio-ulnar synostosis is usually present between 2 to 6 years, mixed. They present with the mid-prone position. In school kids, that is when they go to school, when they don't catch the ball, that is supination is difficult, or sipping a soup from a bowl, then only they come to a conclusion, that is for early diagnosis, that they can suspect for this radio-ulnar synostosis. So congenital absence of humerus, it's a part of phocomelia. That is, here a part of humerus is present, so it is an intersegmental deficiency. Sometimes failure of formation of the ossification centers present in the head of the humerus, which leads to congenital absence of head of the humerus. So by 5 years, all these ossification centers fuse and they join with the shaft. This is shortening of the proximal segment of the limb. So shortening of humerus alone, the term is rhizomelic dysplasia. When the intermediate zone is involved, then it is called as mesomelic dysplasia. And acromelic dysplasia in the distal segment. So example for rhizomelic dysplasia is achondroplasia. This is mesomelic dysplasia in an ultrasonic picture. So mesomelic is involving the forearm, that is the intermediate segment, and acromelic is involving the distal segment. This is a rare case reported in 1942. She was around 42 years or 52 years. She presented, actually the thickness of the right arm was double, and there was a furrow between the two bones. So thanks to the discovery of or invention of Roentgen, that is X-rays. So they did an X-ray and they found out bilateral, there is duplication of humerus along with duplication of scapula. Her humerus articulated with two sets of forearm bones, that is duplication of ulna as well as radius, and 3 hands were there. So you can see here mirror image of the fingers. So what is it responsible is apical ectodermal ridge. So when it is duplicated, it leads to duplication variation. So coming to the bones of forearm, that is radius and ulna, pseudocyst of the radial tuberosity. When this radial tuberosity, X-rays, it can mimic as a cyst. So it's called a pseudocyst of the radial tuberosity. And in one radius, you can see a small pit in the radial tuberosity. So on on an X-ray, it can show as an osteolytic lesion, but it is a normal variant. This is to show variations in the dorsal tubercle of Lister. So dorsal tubercle of Lister was of 3 shapes. One is a hook-shaped, a dome-shaped, and a spike-shaped. It was a retrospective study. So patient presented with extensor pollicis longus tendon rupture. They correlated that hook-shaped dorsal tubercle of Lister presented with more incidence of extensor pollicis longus tendon rupture. Yes, ulnar variance. Ulnar variance is comparing the distal articular facet of the radius and the ulna. When the same length, we call it as neutral ulnar variance. When the ulnar articular facet, the distal end is lower level, we call it as negative. And when it is at a higher level or on the distal level, more distally it is present, we call it as positive level. So in Madelung's deformity, usually it is positive. Congenital pseudoarthrosis of ulna. So again a defect in the distal aspect. Usually it presents, whether it is ulna or radius, it presents in the distal 1/3 or middle. So you can see absence here. Instead of bone, there will be a fibrous card. Since the weight will be transmitted to the radius, it presents with radial bowing. Again, it is rare, only 2 cases per million population, usually associated with neurofibromatosis type 1. Congenital pseudoarthrosis of radius. Radius, again in distal 1/3. Pseudoarthrosis involving both radius and ulna in the distal 1/3. So patient presenting with mid-prone position. So you can see here. Should not be mistaken for a fracture. So this is Madelung deformity with the prominent ulna in the dorsal aspect. So radial palmar, you can see here, that is the ulnar end of the distal radius, either it fails to form or early closure. So that leads to Madelung deformity with positive ulnar variance. Usually presented in girls between 6 to 13 years. Sometimes a ligament can stretch between the lunate and the distal end of the radius, which is called as Vickers ligament. So that can also lead to Madelung deformity. So this is congenital absence of radius, a feature of longitudinal deficiency. It's divided into a radial longitudinal deficiency, ulnar longitudinal deficiency or central deficiency. So this is radial longitudinal deficiency will be associated, can be associated with absence of thumb. So thumb involvement, again associated with bacterial, that is vertebral anomalies, associated with vertebral anomalies, anorectal anomalies, cardiac anomalies. It can be associated with tracheoesophageal septum anomalies, radial deficiency, and limb anomalies, lower limb anomalies. So congenital absence of head of the radius, failure of formation of ossification center of head of the radius, can be associated with the synostosis also. This is ulnar ray deficiency, congenital absence of ulna. Here again associated with synostosis of humeroradial synostosis. This is rare. Ulnar is rare. So coming to bones, the shape we call it as Kerner deformity, otherwise called as distal and phalangia. So in distal and phalange, you can see the same, like the mechanism of action similar to Madelung's deformity. That is the cartilaginous extension, like an L-shaped. So here you can see there is a enlargement and volar beaking of epiphysis. The epiphysis extends upwards. So there will be curving of fingers, the radial aspect as well as the palmar aspect. Incidence is rare, that is 0.15%. Usually it is misdiagnosed as a fracture. So similarly, we have delta phalanx. The shape you can see in the middle. This is os hamuli proprium. Sorry. This is, you have the hamulus here, the hook of hamulus is here. So the hook of the hamate fails to unite with the hamate and it leads to os hamuli proprium. So this is bipartite carpals. Carpals can divide into two. Any of the carpal bones can divide into two and present as duplicated one. So how to differentiate is, usually there will not be any history of trauma and it will be normally carticated, well carticated. Both the bones will be well carticated. Common involved bipartite is a scaphoid. Carpal synostosis. So you can see commonest one is the lunate, between synostosis between lunate and triquetral, followed by capitate and hamate. Sometimes fusion between all the carpal bones leads to complete carpal synostosis. Syndactyly, again it's divided into simple and complex. Simple is involving the skins alone, complex is involving the bones. Commonest anomaly, 1 in 2000 live births. So you can see the fusion. There should be apoptosis in webbing of fingers. When it fails to resorption, then it leads to syndactyly. So mutation occurs between SHH from the zone of polarizing activity, which will be present in the posterior aspect. Congenital absence of scaphoid is reported. When there is a congenital absence of scaphoid, the capitate took over the function, so that articulated with the radius. Ectrodactyly or split hand, as said by Dr. Arun Kumar sir, you have transversely lying metacarpal bone. So you can see here, it comes under the central ray deficiency. Brachysyndactyly, that is adactyly with rudimentary nubbins will be present. Lunula is an accessory ossicle which can be free or it can unite with the ulnar styloid process. It can join with the styloid process. That is joining with the styloid process. This is a free lunula, an accessory ossicle. Supernumerary carpal bones. There are many accessory carpal bones present also. Polydactyly, again one another common anomaly. It can be due to radial. Nowadays we use the word the preaxial or postaxial, that is ulnar or radial type, or it could be central polydactyly also. This is an ulnar polydactyly and this is central polydactyly, extra fingers here with the metacarpals and phalanges. So radial polydactyly, again it is subclassified into either it could be the bifid terminal phalanx alone or two terminal phalanx, bifid distal phalanx or the middle phalanx or the entire metacarpals, all this. This is bifid thumb with a terminal phalanx dividing. So what's the reason behind that is disturbance in the anterior posterior patterning, which is done by this zone of polarizing activity. In this zone of polarizing activity, there will be action of SHH and this will influence. So here is the formation of ulnar side. So when it is duplicated, again that leads to radial polydactyly. There is ectopic SHH in the anterior region. Triphalangeal thumb presenting with three phalanges. So this can be a part of Holtorum syndrome also. There will be mutation of TBX5. So TBX5 mutation leads to, normally TBX5 is responsible for the development of upper limb as well as the heart. So it is also called as heart-hand syndrome. Mutation leads to anomalies in anatomical variants predisposed to symptoms like acromial, whereas some might mimic any pathological lesions, whereas some will have no clinical significance at all. So you should know to differentiate all these three. So there is a lot of scope for research for the PGs in this, variations in the bones, variations in the muscles, nerves, as well as vessels of upper limb. Do it with as a multidisciplinary study that is involving the Department of Radiology, Department of Orthopedics and Pediatrics. These are my references. I would like to thank my mentors, Professor Dr. Hariharan sir, as well as my PG professor, Dr. S.P. Bhanumati ma'am, for mentoring me, for nurturing me for what I am today. My special thanks to Dr. Dhanalakshmi ma'am for giving me this wonderful opportunity. Yeah, thank you.
Thank you, ma'am, for your words of wisdom. I request the chairperson to share a few words.
First of all, I congratulate Dr. Dhanalakshmi, Professor and HOD, Anatomy Department, Thoothukudi Medical College, for conducting the CME. She is my UG mate as well as close friend of mine. And this CME is a long-term dream for her. Once again, I congratulate Dr. Dana. I am happy and privileged to be in this, to be a chairperson of this session, Skeletal Conundrum, that is variation of bones in upper limb, by Madam Dr. K. Subha Ananthi Madam. As a forensic expert, I am very happy, and this session is very useful for forensic medicine people, because we receive many unknown cases, decomposed bodies, skeletal remains, skeletonized bodies, and railway traffic accidents, where the identification is very difficult. When we come across such anomaly cases, as Madam told, that is absent clavicle, absent acromion, then humerus, radius, ulna. If we know that, and we inform the police people and helping the judiciary to investigate with the dentist. You know, many cases used to go to the dentist. So they can investigate with the dentist, orthopedician, surgeons regarding that X-rays they may have this. So thus help in the identification of persons and thus help the society. So thank you, Madam. Thank you, the anatomy team of the Thoothukudi Medical College, for giving me this opportunity. Thank you, thank you.
Madam, some words from an orthopedic surgeon. மேடம் வந்து 2 days முன்னாடி இந்த மாதிரி ஒரு டாபிக் கொடுத்தோன்னே 2 days ஐ ரெஃபர்டு வாட் ஆர் த வேரியேஷன்ஸ் இந்த அப்பர் லிம் இந்த கூகுள். ஸோ ஆஸ் எ சேர்பர்சன் பட் நத்திங் வாஸ் தேர். எவ்ரிதிங் தே டாக்ட் அபவுட் இஸ் அ நார்மல் ஒன்லி. இது எப்படி 15 minutes தானே ஒரு சிஎம்இயில் ஒரு டாக் இருக்கும், இது என்ன 1 hour வேரியேஷன். பட் ஐ கேம் ஹியர் அண்ட் நோ திஸ் இஸ் நாட் ஓன்லி வேரியேஷன், யூ ஹவ் இன்க்ளூடட் ஆல்சோ சம் congenital changes also. Then about this coracoclavicular ligament and hook clavicle and ligament. So every day we do lot of cases. For example, yesterday theatre there was a clavicle fracture, a clavicle plate was applied, there was a acromioclavicular ligament rupture, we repaired it. But now only what the message I want to give is not only this, other than this variation there are lot of shapes, difference in shapes, because nowadays in orthopedics we never use a single plate. For example, now இப்போ டிபியா எடுத்தோம்னா டிபியா மீடியல் டிபியாக்கு 4 இல்லை 8 plates are there. Anatomically contoured plate, anatonically contoured plate. ஏன்னா 8 கம்பெனி இருந்ததுன்னா 8 கம்பெனியோட பிளேட்டும் வேணும். ஏன்னா ஒவ்வொரு டிபியாக்கும் கர்வ் வந்து ஒவ்வொரு மாதிரி இருக்கும். ஸோ வி யூஸ் டு அப்ளை இதில் வி ஆர்த்தோபெடிக் சர்ஜன் வில் ஆல்வேஸ் ஹேவ் 2 except one ஒரு ஆஸ்பெக்ட் ஃபேமிலியை தவிர எவ்ரி திங் வி வில் ஹேவ், வி ஆர் போஸ்ட் டு ஹேவ் 2. அண்ட் பிளேட்ஸ்லாம் கிளாவிக்கல் பிளேட்டில் வி ஹாவ் 8 பிளேட்ஸ். ஏன்னா ஒவ்வொரு கர்வும் ஒவ்வொரு மாதிரி இருக்கும் அதில் வந்து. ஸோ தட் and this coracoclavicular ligament, this joint and all, this very rare. So most of the your topic la vandu with the help of the X-ray we can solve. So the carry home message, this is what me students only, and is as madam showed it for the FM people and orthopedic people. Regarding the supratrochlear groove, we learned, because day and day we do this. You told about the retrograde nailing, but mostly children's we do supracondylar fracture, we put a K-wire. K-wire போடும்போது on the table open பண்ணி பார்த்தா there is a hole. Then we came to know that நிறைய கேசஸ் 10 கேஸ் ஓப்பன் பண்ணும்போது 2 கேஸில் போஸ்டீரியரான போஸ்டீரியர் அப்ரோச் யூஸ் பண்ணும்போது ஒரு ஹோலை போட்டாச்சுன்னா ஆன்டீரியர் இருக்கும், ஆன்டீரியர் கேப்சூல் முன்னாடி பிரேக்கில் அட்ரி இருக்கும். ஸோ then we came to know that that is one advantage for that. when you put a ஒரு ஒயர் போடும்போது அது போனில் இருக்கா இல்லையாங்கிறது, ஏன்னா ஸ்க்ரூக்கு இதுக்குள்ளே வந்துருச்சுன்னா அது தெரிஞ்சிடும். ஸோ இட் இஸ் எ வெரி எக்ஸ்டென்சிவ் டாக். அடுத்தது இந்த congenital pseudoarthrosis, congenital, that is everything is, I want to say it is not a normal variation, it's all congenital. So it's a PG, every PG orthopedic PG and radiology. Most of the, some of the are taken from the Campbell, that is the Bible for orthopedic surgeon, and radiology. So the carry home message is, when you go to the theatre, you must see the X-ray 2 or 3 times and find out whether there is any abnormality or not. But very good, extensively. I thought 1 hour எப்படி இதில் பேசுறதுக்கு என்ன இருக்குது அப்படின்னா. So you have nicely included this pathology and that congenital anomalies also.
Thank you, sir.
Shubhaka, an excellent short and crispy presentation, need of the hour. Sir first வந்து கேட்டார் 1 hour என்ன மேடம் ப்ரெசென்ட் பண்ண போகிறீங்க. இது வெறும் ட்ரெய்லர் தான், மெயின் பிக்சர் வந்துட்டு இருக்கு. The picture was very excellent and carry home message is a lot. Thank you, Ka.
Thank you, thank you.
May I now request the chairpersons to felicitate and honor Dr. Subha Ananthi ma'am with a memento as a token of appreciation for her wonderful session. I welcome Dr. Anita ma'am, Dr. Pavalan sir, Dr. Sita Lakshmi ma'am to the stage. request Dr. Kalamuttarisi ma'am, Senior Assistant Professor in Anatomy, to felicitate Dr. Anita ma'am. I request Dr. Kalamuttarisi ma'am to present this memento to Dr. Pavlin sir. I request Dr. Kalamuttarisi ma'am to present this memento to Dr. Sita Lakshmi ma'am.
Without further ado, let's move on to the last session of the day. I feel privileged in welcoming Dr. S. Satish Kumar sir, Professor of Anatomy, Government Medical College, Kallakurichi, to deliver his session, Variations in the Arteries of Upper Limb, Mystify the Vampire.
Let me introduce our esteemed chairpersons of this session. Dr. G.A. Joss Hemalata ma'am, Professor and HOD of Anatomy in Government Virudhunagar Medical College. Dr. G. Nirmal Kumar sir, Associate Professor in General Surgery in Government Thoothukudi Medical College. Dr. Shrikant sir, Vascular Surgeon from Tirunelveli Medical College. I request the chairperson to introduce the speaker. Over to the chairpersons.
So, very good morning to one and all present here. Anatomy is the mother of medicine. So, with this privilege, I am very happy to introduce Dr. S. Satish Kumar, Professor, Department of Anatomy, Kallakurichi Medical College. Sir did his MBBS in Viswanathan Government Medical College, Trichy, and MD Anatomy, Institute of Anatomy, Madras Medical College. It's my pleasure because sir is the batchmate of Dr. Dhanlakshmi. That is the proud moment to say. And he did his advanced course in CMC Vellore. And sir did his assistant professor in Government Maramangala Medical College, Salem. And associate professor in Government Dharmaburi Medical College. And now he is the professor of Government Medical College, Kallakurichi. These are the posts held by sir. He is the member of Medical Education Unit and the Curriculum Committee member. He was the MEU coordinator at Dharmaburi Medical College and the chief wardens of Men's Hostel now at Kallakurichi Medical College and the treasurer IMU R2 Salem last year and state council member of IMA R2 at present. And he has so many publications, about 7 international and national journals, and is the membership of Society of Clinical Anatomists, life member, and he did his specialization in medical education and gross anatomy, and the paper presented in state 2 papers, best papers award, and he is the speaker in IMA Neurosurgery Conference in Salem. He delivered many guest lectures. And he guided many UG students in paper and poster presentation in various conferences. So now I hand over the session to Dr. Satish Kumar.
Thank you for your kind introduction. Good morning, faculties, chairpersons, and UG and PG students. So this session, this is a pre-lunch session, so all of you get tired, I think. So now we are going to see the variations in the artery of upper limb. So we know in undergraduate level, so artery, we will draw the diagram, we will know the theory of extent, branches, everything. So once if you go to clinical practice as a CRI or postgraduate, so we know the vampire phase of the artery. If it is abnormal, it will produce so much of a problem to a hemorrhage, hematoma like that. So for that, we should know the normal arterial pattern as well as the variations in the arteries of upper limb. This session we are going to see. So the already overall your brain will be full of variations of artery. Now we are going to see artery. So now muscles and bone. So now we are going to see about the arteries of upper limb normal than the abnormal. So because of pre-legislation, so I highlight the important variations we can see in the upper limb. So the objective of this session, so we are going to see variations of artery of upper limb and its embryological basis, then clinical significance of this variation. So nowadays various interventional procedures in radiology, cardiology and also ortho, plastic reconstruction surgery. So the variations is very, very clinically significant. So upper limb arterial pattern, all of you know. See the axillary artery we are going to see in arm, the brachial artery, radial artery, ulnar, then the superficial palmar arch, deep palmar arch. So we'll see from arm to hand later. So variations of artery. So variations is not uncommon. So it is somewhat common. So the incidence is about various studies. So in major textbooks, minimal variation they are given, but recent papers, studies, the incidence will be from the 18 to 20% variation we can find in the arterial pattern of the upper limb. So first we'll see the axillary artery and its variations. So we know the extent everything. So the branching pattern of the axillary artery, so it has three parts. So the first part, superior thoracic artery, it gives axillary artery. Then second part, thoracoacromial lateral thoracic. So third part, subscapular anterior humeral circumflex and the posterior circumflex humeral. So this is the normal branching pattern. We can see this superior thoracic artery, lateral thoracic, then the third three branches from the third part. So what are variations? So number of variation, we know the 6 branches from the axillary artery, it may vary from 5 to 11. So the muscular branches, so we're going to see they are directly arise from the axillary artery, number will be increasing. So the branching pattern, so various studies, the incidence, superior thoracic artery, the variation, that origin from 1 to 5% it varies. So similarly, thoracoacromial artery 1 to 10%, lateral thoracic, so up to 9.6% variation we can see. The subscapular artery 5 to 15%. So they already we know it arises from the axillary artery. The superior thoracic artery, first part it arises. Instead of variation means it arises from the second part of axillary artery. Thoracoacromial artery, so it arises as a common trunk with the lateral thoracic artery. So the lateral thoracic artery, it arises from second part. Instead of variation, common thoracic arises from subscapular artery and also the common trunk with the thoracoacromial artery. So similarly, the variations are more common in subscapular and the posterior circumflex artery. So there it will be having the common trunk with the anterior circumflex, common trunk with the subscapular artery from the second part of the axillary artery. So here now we will see what are the incidents. So according to the previously we have seen. So here in this picture we can see the common trunk for the subscapular, thoracoacromial and the posterior circumflex artery. So here also we can see the posterior circumflex and the anterior circumflex has a common trunk. So here the percentage, here 10% variation, the thoracoacromial artery and lateral thoracic artery arise from as a common trunk from the second part of the axillary artery. Here in this picture we can see the lateral thoracic, that is subscapular artery, then the circumscapular artery, they will be arising from the common trunk. Here we can see this percentage of variation very, very minimal, but this is clinically significant. So common trunk, so thoracoacromial, then subscapular and the lateral thoracic artery arise from as a common trunk. Here we can see the posterior circumflex. Here the common trunk as the thoracoacromial trunk and the lateral thoracic artery. Here the subscapular circumflex also here we can see. This is important. So the 13% may arise this deep brachial artery, that is profunda brachial artery may arise from the third part of the axillary artery. So it is somewhat common. We can see here. You can see the posterior circumflex arise from here. There is deep brachial artery. Previous picture we have seen from the third part. Here we can see the posterior circumflex humeral artery. So here also you can see posterior circumflex as well as the profunda brachial. Posterior circumflex arise from the profunda brachial artery, that is arising from the axillary artery. Here we can see the accessory, that is double lateral thoracic artery from the second part of the axillary artery. So here we can see the circumflex scapular and thoracodorsal, they arise from the subscapular artery, but here it is arising as a separate trunk from the third part of the axillary artery. Here the extra thoracodorsal artery variation, so they are all minimal in percentage. So recent studies here they have classified this common trunk pattern into three: type A, type B and type C by the Tiwari study. It states here we can see the lateral thoracic and the subscapular artery arise as a common trunk. Here the anterior and posterior circumflex humeral artery arise from the common trunk from the third part of the axillary artery. Here we can see the thoracoacromial lateral thoracic arise as a common trunk from the second part of the thoracic. So here we can see the dissection pictures of this variation. Here we can see the superior thoracic artery. So it usually arises from first part. Here from the second part of the axillary artery it arises. Here the common trunk of lateral thoracic subscapular. Here we can see the common trunk. From here the lateral thoracic subscapular artery, they arise from the common trunk from the second part of the axillary artery. Here we can see the common trunk for the subscapular artery and the posterior circumflex humeral artery. Here we can see the subscapular artery arise from the third part of the axillary artery. In this picture we can see the common trunk for the subscapular posterior circumflex humeral artery from the common trunk. So here the three arteries from the axillary artery as a common trunk: lateral thoracic, posterior circumflex humeral and the subscapular artery. So they arise as a common trunk. Here we can see in this picture also the axillary artery, the common trunk arises for the subscapular artery and posterior circumflex humeral artery. So they are all common trunk having the more variations. Similarly here you can see the common trunk for the anterior and the posterior circumflex humeral artery. So here one more variation in the third part of the axillary artery. Here one additional subscapular artery arises from the common trunk for subscapular artery. Here we can see the picture of the same. Here, so the clinical importance of the axillary artery. So already we have seen a lot of interventional procedures are done. So for treating the axillary artery thrombosis and antegrade cerebral perfusion aortic surgery, then the thoracodorsal and circumscapular vessels are used for the flap surgeries. So then the variations will be resulting in the flap success rate, and also the axillary artery hematoma, the microvascular graft will be, we have to correct it. Further the branching pattern is very, very important. So otherwise it is very difficult to clear the axillary artery hematoma. So then the safe zone. So here between the lateral thoracic artery and the thoracodorsal, this area is, so this area is safe zone. Following the axillary node dissection, so following carcinoma breast as well as in melanoma, so the axillary node will be axillary node bearing tissue will be removed from this area. So this area is said to be a safe zone area. Okay, so then next we are going to see about the brachial artery. So we know the brachial artery from the lower part of the teres major to the neck of the radius, the extent present. So the branches. So the branches, profunda brachial artery, then superior ulnar, inferior collateral artery. So the length of the brachial artery vary from 21.5 to 22.65 in various studies. Here already we have seen these are the branches already you know. So the terminal branch is the radial and axial artery. So variation of the brachial artery will be having, so these are some common variations for the brachial artery. The superficial brachial artery, high origin of the radial artery, high bifurcation of the brachial artery, high origin of ulnar artery. So in that the superficial brachial artery is somewhat common, and also the high origin of the radial artery also very common. Here we can see the brachial artery, that is high origin. Here in the arm itself it divides into ulnar and radial artery. The important significant is, so if the higher bifurcation occurs, then the artery will be having tortuosity, both bifurcation. So that will be difficult in doing the catheterization procedure. Here you can see the high division of the brachial artery, here also the ulnar. So in the arm itself we are having this division. So then coming to the superficial brachial artery, this is also one of the common variation. So why here normally the brachial artery related, that is median nerve relation lies in the upper part of the brachial artery, it is lateral, then lower part it is medial. So if the superficial brachial artery lies superficial to the median nerve, that condition is called superficial brachial artery, that is superficial to the median nerve. So this is very, very important. So the superficial brachial artery is more for injury, during the accidental injury. So it will causes rupture of the vessel and profuse bleeding will be there. So then sometimes it will be mistaken for median cubital vein, so the blood will be drawn, that will produce bleeding and hematoma. So then median nerve relation we have seen the superficial brachial artery, so related with median nerve, sometimes because of the tortuosity or compression of the superficial brachial nerve will produce pain during the distribution of the median nerve, and also it will be similar to carpal tunnel syndrome. So this accidental, this is because the superficial brachial artery, so normally if you don't know this variation, so the accidental intra-arterial injection, so may produce sometimes gangrene of the fingers and hand and forearm. So the brachial artery procedure, so better we should do Doppler ultrasound, so angiographic study before major procedures of the brachial artery. So profunda brachial artery, so this is one of the branch of the brachial artery. So there are branching pattern by the Charles et al. So there it is, we will be having the 7 types of branching pattern. So here the percentage more common is what we study is the branch from the brachial artery, that is 54.7%. So this type 1AB, they will be having the separate branch, 2 separate branch, 3 separate branch from the brachial artery. Sometimes this profunda brachial artery arises from the along with the common trunk with the superior ulnar collateral artery. So this is very, very important. And also, so sometimes this profunda brachial artery, already we have seen the axillary artery, it may arise from the third part of the axillary artery. So the type 4, here the common trunk with the posterior circumflex humeral artery, the profunda brachial artery arises. Then in type 6, the common trunk with the subscapular artery as well as the posterior circumflex humeral artery. These are very, very less in number. So the type 7, the profunda brachial artery may be absent. So these are different types of the origin of the profunda brachial artery, otherwise called deep brachial artery. So here we can see the picture. So here the profunda brachial artery, we can see the common trunk for the, here you can see the common trunk. So here also from the axillary artery, the profunda brachii artery arises. So the clinical importance of this profunda brachii artery, so the duplication or early branch may, already I told, so sometimes the tortuosity of the artery will be present and the branching pattern will be different. So this will be complicated in the lateral forearm flaps. So the coming to the radial artery, so radial artery very very important because this will be used for most of the upper limb intervention as well for the coronary angiogram, CABG, everything. So this radial artery, course of the radial artery, the branches are recurrent radial artery, superficial palmar branch, then the arteria principis pollicis, then arteria radialis centisis, then palmar carpal branch, dorsal carpal branch. So these are various branches from the radial artery. So the high origin of the radial artery, one of the commonest variations in the radial artery. So the different name is given for this high origin of radial artery. One is the brachyradial artery. So in the brachia, that is from brachial artery, the radial artery arises. Then high origin of the radial artery. So radial artery originating from the axillary artery. Then high bifurcation of the brachial artery, double brachial. These are different terms will be given by different authors as well as by the high origin of the radial artery. Here we can see in this picture the radial artery arises from the axillary artery. So here we can see the from the axillary artery the radial artery arises. Here the hypoplastic of the radial artery, so normal branching from as usual from the here brachial artery. So here the superficial, this is called superficial radial artery, it is also a hypoplastic. Here we can see the brachial artery, so the radial artery arises as a high origin. You can see the tortuosity of the brachyradial artery we can see. So that is very very important. Here also we can see. So one more thing, if the that is high origin of the radial artery is present, there will be communication between the, here you can see this is normal branching pattern. So if the high origin of brachyradial artery will be present, there will be a communication between the brachial artery and the high brachyradial artery. So that is called cubital crossover or cubital connection. The variation it will be present from 5 to 10%. It is clinically important because of the accidental. So it will be confused with the median cubital vein. So it is very very important. Here we can see the dominant type of. So this is dominant type of cubital crossover because it will be diameter is more than the high brachyradial artery. Here the diameter is same as. So this is called balanced type. Here this is different. Here you can see the hypoplastic, that is communication of artery, that is cubital crossover, diameter is very very less. So that is minimal type. Here no communication between the high origin of the brachyradial artery and the brachial artery. So this is a picture showing the dominant type of cubital crossover. Here we can see the this is radial artery. Here we can see the cubital crossover. So here the hypoplastic artery, brachyradial artery is there. So this is the diameter is more than this. This is called dominant type. Here the balanced type. So the brachyradial artery and the cubital crossover, they are all same in diameter. You can see here. So the minimal type of cubital crossover, here the size of the crossover is very very less diameter. Then here we can see the absent cubital crossover. So the next branch variation, here you can see the recurrent radial artery arising from the radial artery. So the accessory recurrent radial artery incidence from the 1 to 2.57% is there. So this is you can see the accessory recurrent radial artery, 2 in number in this picture. So here the clinical significance of this recurrent radial artery based flaps used for microsurgical and around the elbow. And also, so the survival rate of recurrent radial arterial flap is high. If the accessory recurrent radial artery is present, so the success rate is more. Then coming to the common intraosseous artery. So common intraosseous artery from the radial artery. Usually common intraosseous artery arises from the ulnar artery. So the variation percentage between 3 to 12% studies shows. Here the common intraosseous artery arises from the radial artery. So the clinical importance of the radial artery. So this is the most common artery used for the CABG after the right and left internal mammary artery. So because the radial artery diameter is equal to that of coronary artery. So and also the radial artery used for so the puncture and the cannulation for the procedures of the interventional procedure. So already I have told the high origin of radial artery more prone for accidental injury because of the superficial in nature. And the blood pressure, usually blood pressure will be recurrent in brachial artery. If high origin of radial artery will be that the brachial artery will be less prominent. So it is accuracy will be somewhat less. So the high origin of the radial artery, if artery arises higher level, the diameter will be less. So the increased chance of failure of transradial catheterization is there. So the knowledge of the high radial artery is very, very important. Then coming to the ulnar artery, so it is one of the terminal branch of the brachial artery. So branches we all know. So the important anterior posterior ulnar recurrent artery, then common intraosseous artery, then muscular branches, then dorsal carpal deep palmar branch and the superficial palmar branch. So the here the already we have seen radial artery, high origin of the radial artery. Here also the superficial ulnar artery. The variation may present from 0.7 to 9.5%. Here in this picture you can see the superficial ulnar artery. So that is high origin from here in the arm itself. So this is superficial ulnar artery. So the diameter is larger than the radial artery. Ulnar artery is less used because of the deep in location. So any injury, so it will cause hematoma. That's why when compared to ulnar artery, radial artery is preferred. So the plastic surgery, so the medial forearm flap will be successful because of the ulnar artery branches. Then the superficial ulnar artery is good source of blood for the forearm flap. So here next we are going to see about the superficial palmar arch. All of us know this is the dominant artery in the hand. So for microvascular surgeries of hand, this integrity of the superficial palmar arch is very, very important. Because so Coleman and Hansen classified this palmar arch into complete and incomplete superficial palmar arch. So here we can see, so now what normally we know, so it is formed by superficial branch of the radial as well as superficial ulnar branch form the complete palmar arch. So it the incidence is about 34% according to this. Here the type B you can see the superficial palmar arch is completely formed by the ulnar artery here. Only the medial side, that is lateral side of the thumb, it is formed by the radial artery. Here you can see the complete arch is formed by the ulnar as well as median artery. Here both all the median artery, radial ulnar artery forming the superficial palmar arch. Similarly, the incomplete superficial palmar arch, here you can see the arch is not complete, but the vessels ulnar artery here in the type F, here it forms the 13.4%. So here the ulnar artery from the major, that is first intermetaphyseal phase to the third, so it is blood supply. So the lateral aspect by the radial artery. Okay, so this is different classification of the superficial palmar arch. So already we have seen the major one is by the type A that forms the 34.4%. So here we can see the type A, that is commonly what we see is the complete superficial palmar arch. So the type B, we have seen the superficial arch is formed completely by the ulnar artery. So the incomplete arch we have already seen. So here we can see the incomplete. So type F of incomplete palmar arch. Here also, here the H type, it is the incomplete, it is formed by the ulnar artery and a median artery alone. So the incidence of this superficial palmar arch, various studies are there. So mostly the type 1 of complete arch and type that is incomplete arch is more common. So the clinical importance, superficial palmar arch, already I told. So the arterial supply is very, very important for the hand. Any injury or during surgery, constructions, that is injury to the superficial palmar arch, the radial ulnar artery, that is anastomosis, will not be significant. So similarly, the radial ulnar artery, if we are taking any graft, so this superficial palmar arch should be completed, study should be completed, otherwise the fingers will go for gangrene. So far we have seen the important variations, arterial variations of the upper limb. So this is mainly these variations are due to the embryological arterial formation. So any deviation that will produce the variation. So you all know the artery of the upper limb arises from the 7th cervical intersegmental artery. So that only forms the proximal part, that is axillary, then the brachial artery, then the distal part from the intraosseous artery, anterior-intraosseous artery, then this is digital plexus will be present. So this plexus will be communicated by the latter by the origin of the median artery from the anterior intraosseous artery. So later you can see here the superficial, in the stage 4 of the development, superficial brachial artery can arise from the brachial artery. Here you can see this continuous as the radial artery. So ulnar artery separately it arises from the brachial artery. So because of the arterial variations, mainly you can see here the dotted lines are the disappearance will produce the normal arterial pattern. If it is persists, that will produce the arterial variation. You can see here the superficial radial artery arise from the here because of the disappearance of the anastomosis between the normal radial artery and the brachial artery. Here you can see the superficial ulnar artery. Superficial ulnar artery, because of the persistence of this anastomosis will not disappear. So the persistent disappearance and unusual path of the blood vessel will lead to the variations of the artery of the upper limb. So the conclusion, coming to the conclusion, the knowledge of the arterial variation of the upper limb is very, very important, because various interventional procedure and radial arterial graft are done in the upper limb. So the variation will produce knowledge. If we correctly identify, that will give the success rate for our treating of the surgical procedures. So with this I will conclude. So these are my references for this study. So thank you for patient listening. So I thank Dhanalakshmi ma'am for guiding me from my PG days onwards till this presentation. Thank you ma'am. Thank you.
Thank you, sir, for your words of wisdom. I request the chairpersons to share a few words.
Yeah, very good afternoon, everyone. Hope you're all getting ready for a gastronomical experience, so we'll not take much of your time. At the outset, I would like to thank the anatomy department for bringing out such a beautiful CME, and thanks to the speaker. So after hearing all the 4 topics, we think divergence is the dictum today. So previously, we don't come across this much of variations, but thanks to the imaging facilities, so before getting into surgery as such, we could know what we are going to deal with. most of the time when probably say 10 years ago when there was not much of imaging, most of the time it would be a surgical surprise for us. And especially in an arterial system, one inadvertent move and it will be a vampire thing, we have to lose the limb. But you have beautifully brought out all the variations, sir, and especially the safety zone in axillary dissection. It was an excellent session. Thank you very much, sir.
Thank you, sir.
Good afternoon to all. First of all, I thank anatomy department, which is actually more closely related to me. For a couple of period of months, I have worked under Dhanalakshmi madam over there. So I have some better experience in anatomy department. I thank the department for giving this opportunity. And I also congratulate and thank the speaker for giving excellent details regarding the anatomical variations of the upper limb. So some clinical points which I like to share regarding vascular aspects is from the actually the symposium. So the variations which we commonly encounter are mostly from the profunda brachial artery or the deep brachial artery and the branching of the brachial arteries. So the profunda brachial artery, if at all it is absent, as Sir said, as a minimum occurrence, any injury to the brachial artery will immediately threaten the limb and we may lose the limb. So we used to call the profunda brachia as the savior of the upper limb. So because it may not be injured often like that of a brachial artery, and it will somehow manage the limb to sustain till the patient reaches. So that is very important, and those percentage of people